We are live.
A very good evening to one and all present today, and it gives me great pleasure to welcome you to another episode of AIOS Guru Sangam, the 2024-2025 edition. Educate, Elevate, and Exceed. This has been an excellent program that has been running the rounds for the past couple of weeks for the benefit of PGs, hosting a galaxy of faculties from all around the country. It gives me great pleasure to welcome all of you to episode 18 that will entail publications and miscellaneous. Today is the 23rd of February. Uh, Without further ado, I would like to introduce our chairman, Dr. Samar Kumar Basak sir, President AIOS, under whose umbrella and visionary guidance this Guru Sangam is taking place. I would also like to introduce our program directors, Dr. Santosh Honavar sir, Honorary General Secretary of AIOS, and Dr. Manoj C. Mathur sir, Honorary Treasurer of AIOS, for conceptualizing and being the brainchild of this program all throughout its entire season. Today, we are joined by an expert panel to discuss for PGs and for the benefit of young ophthalmologists. I would like to introduce the panel one by one. Dr. Arpan Gandhi from Shroff's Charity Eye Hospital, New Delhi. Dr. Geeta K. Vemuganti from Hyderabad. Dr. Lalita Vasu Kamal Devi from Amala Institute of Medical Sciences, Thrissur. Dr. Purvi Bhagat from MNJ Western Regional Institute of Ophthalmology, Ahmedabad, and Dr. Sabyasachi Sen Gupta, Future Vision Eye Care and Research Center in Mumbai. It also gives me great pleasure to start off with the very first lecture of this scientific extravaganza. I would like to introduce our first speaker, Dr. Deepak Mishra, who is a professor, Regional Institute of Ophthalmology at BHU Varanasi, Uttar Pradesh. He is the honorary secretary of the SICS. He is a council member of the South Asian Academy of Ophthalmology. He is a member ARC of AIOS, the chairman scientific committee in Uttar Pradesh Ophthalmological Society, and the founder of PG Examination Forum. He has many academic contributions, some of which are book and chapters uptailing to 21 and 105 peer-reviewed publications. He has a number of honors and awards to his name, including 55 awards, 15 gold medals in scientific forums, including but not limited to the AIOS Achievement Award, AIOS Lacrimal Award, and IGO Silver Award. I would like to invite Dr. Mishra to speak on the art of scientific writing to the PGs today.
Thank you, Dr. Amjit, for lovely introduction, and Dr. Santosh Navar sir and AIS for giving me this opportunity. Are my slides visible?
Yes, so they're visible, but they're not yet in full screen. So I'll just let you know when you reach full screen.
It's here from my
सर एक
side.
बार स्टॉप करके दोबारा कर दीजिए.
Stop sharing. Now it's on full screen.
No, sir.
So you have to share, sir.
Just now it's on full screen.
Yes, it's on
Perfect,
full
sir.
screen.
Perfect.
It's moving.
Sir.
Sunilji, it's moving.
Sir,
Yes,
all
yes,
good,
sir.
sir. Please.
You can begin, sir.
Thank you, sir. Thank you for short.
Sir, just click on the screen and it should be moving.
Okay. Just it's the topic allotted to me is the art of scientific writing. there is no financial disclosure. So first of all, what are the most common reason or why we are supposed or people are nowadays or every time writing anything for the scientific literature? Still after long time, the number one is the thesis, means whatever the thesis proposal, most of the time these students, guides, and other one would like to go and publish it. And second most common reason is for the funding. So these are the two things which we have to keep in mind. One is the thesis and another one is for the funding is the major causes still for the writing of scientific literature. Before going to the different types of the scientific literature is there, means we have to understand few terminologies, means for what and what we are writing. First of all, there is a case report. Case report is usually less than 3 in number. For anything which you have to find out, means it is an unusual or uncommon things which you want to publish in a journal. Another one is the case series. Case series is almost the same type of the case reported, having similar or uncommon or common features or some surgeries for new things, and it is having a higher number, means somewhere it is 3 to 7, somewhere it is 3 to 10. You can combine it in all and publish. Review literature is the article which you can write just like a story wise from the chronological order from A to Z, whatever the things available on that. It may be with the help of the software or you can write, but do respect to reference at everything. Another thing is the original article, which we are going to discuss in detail in today's talk, means whatever the study we plan and how we can write and proceed for it. But before writing, I always suggest few things we have to know. One thing is what you are going to publish, which I have already mentioned, means you are going to publish a case report, case series, or the original article. And another one is which journal. Why this is important, means where we are going to submit our article is best important. Means important is for that because few journals accept only the case reports. So if a journal is designed for the case report and anyone is submitting original article in it, it doesn't accept it. Similarly, few journals going to accept only the review article. So you have to know means that which journal you are going to submit and whether the audience of that journal or the target you are targeting the audience or the article type of that journal or not. And another thing is we have to know whatever the publication guideline and what are the article guidelines for the publication, because when you are going to write then we have to know means what is the guideline by which the journals want the submission. So any research paper or the article can be divided or gone into these 3-4 important segments. One is the title, which clearly describe whatever is the content. Then you have to write everything about the authors, their name, mobile number, email number, contribution, their professional associations. Abstract is one thing which we have to describe, means what was done and what we are going to add. Also add 3 to 5 keywords for each abstract because it helps in indexing and this abstracting the when anyone want to search your article, he or she can just type the abstract and go. And after that, the same for that is the introduction, material method, results, discussion, acknowledgement, and the references. So coming to the article first, article is the line content which describe your whole project or the thesis or even your scientific content. But few things we have to know about the article, means how to write the title. One thing is this content should be concise. It should be an specific. Ideally advisable that don't use any abbreviations or avoid interrogative questions. And one thing again important is it should not be too long or complicated that anyone can go. So I'm going an example of each so that we can understand it better. The example of concise means here we can write like a novel study on the usefulness of S1 antigen detection in the dengue fever in children. So main study or the main profile is whether we want to know that this N1S1 antigen detect dengue fever in children or not. So make it more concise and make it like that N1S1 antigen test for the diagnosis of dengue fever in the children. By this way, we can make our title concise, specific. Like if this is an article means title means vitamin D and congenital cataract in children. So the readers cannot understand whether this is a maternal vitamin D or the children's vitamin D level and what is the which type of congenital cataract we are talking about. So it is a very broad and non-specific type. Whether this vitamin D is hypervitaminosis or the hypovitaminosis, which will lead to this cataract. So the correct way to write this one is if we write out or write in a such a way like association between the maternal plasma D level and the congenital cataract in children. It clearly says or we can understand that the study is on the how a deficiency or the association of vitamin D in the mother's blood affects or lead to the congenital cataract in such children. Abbreviations like you have seen here, that is the variation in CCT during the MC in the Indian woman. Again, don't use this CCT or MC in the title. You can clearly write that is a central corneal thickness on the menstrual cycle. Like that way, we can avoid abbreviations. Again, I am giving you an example how to reduce a very long title into the small and the specific one. Like we did one survey which was on the topic that how much COVID affected the residency training program. And you can write it anything like 3 or 4 lines in where. But the important thing, what we want to know only is means what is the how much or what is the impact of this COVID-19 on the ophthalmological training in the India. And again, it is a survey. So instead of writing this in 3, 4 lines, you can simply write the impact of COVID-19 related lockdown on the ophthalmologic training program in the India. Now, after the title, coming to the abstract. Abstract is one which summarizes our study, and usually different journals have different word guidelines. Means it is somewhere 150 to 350, somewhere it is up to the 500 words in which you can write the abstract. Abstract also include your keywords by which we can search the article. And one of the important thing, we have to write abstract in a such a way because most of the time readers only read abstract and then they will decide whether they will go for the whole article or not. And another thing, there are many suggestions. Few suggest that they can write abstract at initial stage and write the whole article, but I usually suggest that accurately write whole article and then write the abstract and again revise it twice and thrice to make any mistakes. There are different types of abstract. These abstracts, according to the journal's guidelines, may be of 4-point abstracts, means they want your study in the heading of purpose, methods, results, or the conclusion. Like here it's in the KJO you have seen, this is a 4-point abstract example, means whole study is included in this. Not even the original study, but the case reports also. You have seen this is a 4 type of abstract, means abstract is divided into the 4 types, either it is case report or the original articles. Somewhere somewhere journals wants it in a 8-point abstract. These 8 or 6-point abstract, basically they want the methodology in the details. Means if you are writing a method, you have to tell what was the study design, study setting, how many participants we are using, what was the intervention, and what was the outcome. So objective results and conclusion is same, but the study methodology or the material and methods in 8-point abstract is written in a detail. Some journals want like clinical and experimental ophthalmology. It is an unstructured abstract, means they only want an abstract of 100 or 200 or 300 words, but it will not divide it into any subtopics or subheadings. So these are the type of abstract. And the common mistakes we usually found out in abstract is too much background or the method information. No, abstract is just only for the reading. So use it as short as possible in a concise way and avoid references. References is usually avoided in the writing any abstracts. After that, next four things which are title and abstract, we will going to discuss about introduction, material methods, results, and discussion. Coming to the introduction. Introduction clearly states what is the background or what is the problem behind your doing this study and the reasons for the conducting the research. Also, it summarizes the relevant researches or the things done in the past. And at the end of the introduction or at the last paragraph of the introduction, it is advisable to write or something how this your article or the scientific literature is different from the published one. So I am giving you this example. This is our survey on the impact of webinars during the lockdown. So in the initial few lines, we clearly mentioned that why these webinars are going so frequently. That was the COVID-19 lockdown. That's why the region was going. And then in the same paragraph, we write what was the region or what is the webinar, what we want to do. Means these are webinars are not only conducting in India, but across all the places. Similarly, we have to write means state that what is your work different from the published work. So here is the article on the essentials of setting of wet lab. Here we have already mentioned in the initial two paragraph that what are the researches are the things done by the previous author and why we are going to write this in review article. Here in the last paragraph of the introduction, we clearly mentioned that there are the various improvement in the wet labs techniques and trainings over the years. So we want to summarize. So start your abstract from the training program is from the initial and at the end always write why you are going to write it in the introduction. Coming to the review of literature is something means we have to provide whatever the research is done in the past and it will be just like an story. If you have write it in a chronological order in a best way, it will be good. And again, at the end of your review of literature, we have to write out something, what is the lacuna in the present literature, other topics, other thing. Like this was our study on to compare the conventional versus the power implant in the DCR. At the first line, you have seen here that we have written that whatever the DCR or the several modification has described by Toti et al. In 1904. And similarly, we write increasing in an order means who have done, what was the study done, and summarizes that. Similarly, here is the problem means what is the lacuna in the present knowledge. We already been in this study, we have seen the assessment of optic disc likelihood damage ratio. We are going to correlate with in the internal or initial lines. We also write that there was an high inter-observer variability and low reproducibility. So here is the lacuna means there is no confirmatory or there is high inter-observer variability. So we plan a study which correlates means the diagnostic efficacy of slit lamp or this OCT means we can avoid this lacuna by conducting this study. So this was our plan of the study. Coming to the material methods. Material methods clearly explain what was the study we are going to plan and identify and retain each and every points about your study procedure. One thing is important, whatever your ethics or declaration is there, you have to write it in the material methods. But always remember these 5W. I always say these 5W is important for writing material method. One is what was done. What was done means what was a study design. Whether it is a prospective study, retrospective study, randomized, non-randomized or anything. Study design is again a big topic and you can go and see the previous webinars of IVSARC. Dr. Savsachi Sen Gupta is here. He's also doing lot of webinars and online training methods for writing and explaining about the statistics and study design. Again, you have to go for the Who means what was your study population, whom you are going to conduct this study, what is your inclusion and exclusion criteria. Third is when, means what is the time frame, means what is the time frame by which you have to complete the study. Then the location of study, whether it is a hospital-based, primary or tertiary. And finally, the described what was the detailed procedure. So remember these 5 Ws for the material and methods. Like if any of the study is done and you have done it, means given them the exposure, then it will be clearly go into the randomized study. If it is not only an observational study, then it will be a comparative group of study where it will be analytical or descriptive. I'm not going in detail because it's again a different thing, but showing you one example of each. Like here you have seen we have done enrolled 140 patient and randomly divided them into 4 different groups to find out what was the IOP lowering efficacy of these drugs. So in the randomized study or the material method, you can write in the initial, make a chart of like that we have enrolled and we go like that. And you can also write what was your study plan, means at baseline what you are going to check and at next term what you are going to check. In a non-randomized study, here you have seen fibrin glue versus conjunctival suturing in tertium, means we didn't randomize them that this group is going for the suturing or the fibrin glue. It's just a comparison or the study, means whatever the things is available, you do and compare it. For the observational study, it will be into 2, analytical and descriptive. Just use a proper adverb. What we are seeing at the time of reviewing article is the article is type is different, the study done is different, but this adverb done is used in that writing the abstract or the material method is wrong. If it is a descriptive study, then estimate, study or describe. If it is an analytical, then again use, determine, examine and the compare. I am showing you one example of this. Like here we have did same. The external, whatever we have compare, it is an analytical study where you just use a comparative study, means you can see that we compare each and every parameters in 2 different groups. One, the surgery done by the conventional technique and other by the power implant. So if you have done a study which compares 2 different outcomes, then you can write it comparatively. And this is an example of descriptive. Here is the, we simply find out what is the role of cyanoacrylate glue in different ulcers. Here we have not compare anything. It's just a case of any ulcer and use cyanoacrylate glue and whether find out whether it is useful or not. Another thing which is important is about what I have said. Always write about design, whatever is the location of study and time frame. Here, if you've seen in our article, even at the end, from the initial 2-3 lines, we started with the same thing. Means whatever is the study design, means we have done the prevalence of incidental and total HIV population. It is a cross-sectional study design. Place where it done, it's clearly written that it is done at Banaras Hindu University, RIO, and the time frame. Yes, somewhere if you are find out these things are used even in the title too, means they have written a randomized 36 weeks trial, just like that. So whether you are right in title or not, but in the methods, it is important to write about your study designs. Again, statistical description is very much important in the material method. You have to write out what is the software details, means if you are using an SPSS software, then what was the version, what was the make, whether it is free or the trial version. And again, if you can write about the data types and the analysis, means if it is a quantitative data, then you have expressed into mean or SD. If it is a qualitative data, then you have to go for the chi-square test or that. Write at least 1 paragraph about your statistics in this. Also, the sample size calculation is important. Now coming to the result. Result is something which is just like here the number. Remember that result is in mathematics. You don't have to compare, just write whatever you have find out and show it in a proper way. You have to summarize the data with the help of the statistics and accurately measure, means in the result you have to write whatever the statistics or the maths you have used in it. means what is the mean, median, mode, or the p-value. Like here you've seen in the one paragraph, in the one table, you have find out what is the range of the different groups, what was the study design, whether it is significant or not, the p-value. So you have to write it each and everywhere. Somewhere it is written in the percentage, with what is the percentage drop in the IOP. So if you are using a result, then write in statistics. Another thing, you can use these different figures and the diagrams for the showing your study or the article. Use a representative data and the proper caption. One thing is important, that whatever your figure you are using should be in high resolution. If you are using a case report, then it is must. Like here you have seen, we have used figures. Again, I am advising you to go for and see what the figure ligands they want. Means somewhere it is written to write the figure in the form of A, B, and C. You can make collage and write it, or somewhere it is written if you can write 1 and A simultaneously behind it. So whatever the ligands you used in the figure and what is the guideline for the journal, also go for this. Also, you can go and write, means where they are using this type of figures. Means if you are using any pie chart or anything, then if you have compare or use these parameters or the percentage at the data levels, or that, it will be good and it looking good for you. But again, go for the and go as per the general advice. What things should be avoided? One thing is, don't discuss or interpret your result. This is the most common mistake. Most of the time you started discussing your result, and don't include any references, because these are the your own results which you have studied and find out. Third important thing, most of time at time of review, you will find out that reviewer suggested there is a data representation. Means you have repeated the data, same thing in the table, same in the photos, same in the figures. So avoid it. So we have to know that, as when we are writing a result, don't interpret the result, don't include references, and don't represent data more than one times. For the when you are writing thesis, it's common that you have make a table and make a graph for that. But in the scientific literature, it's if you avoid it, it's best. Discussion is the segment where you can interpret your result. Means here you have to compare your results or the findings with the another one. Like here you have done, we have write a review article on this, whatever the corneal transplant technique and outcome, and we compare whatever the year of the article is there, means study many years, what was the number of eyes used by all of them, what was the mean age of the surgery, follow up on it. So here in the part of the discussion, at the end of, if you are planning any study, write your study or the findings of my study too, and you compare it with all the previous researchers done by it. One thing important is that don't have any agree with or not agree with any of the data or anything, but whether we have find out the results which are uh, just suitable as are the aligned with the previous publication or not, it doesn't matter. If we have any negative results, or if whatever your result is there, you just discuss and write it. Don't hesitate in writing any negative results too. And the implementation of the study, or at the end of the your discussion, always write what is the lacuna and how will you improve, or what is suggestion for yourself for the future researches. Like you have seen, this is our study, and in that the last of the study, at the discussion portion, we clearly write whatever is our study lacuna. And here we suggested that if we plan this study on a larger sample size, are done at the multicentric studies, then we have a better correlation between that. So limitation of your study, and also suggest whatever we can do or what the future researcher can do in your study. Coming to the conclusion. Conclusion is the main purpose for the writing. Means if you are writing a conclusion, be very specific. Means what is the real significance or useful of your study, and if you are able to formulate a topic or write what is the future implementation of your topic or your whole study, you write it. But remember that conclusion is within 2 or 3 points. It will not like a 3 pages or 4 pages of the discussion. So I am showing you one of the important thing, like we did here, a clinical and histopathological correlation of the multiform blepharosis. And here you have seen in the first paragraph, in the first line, it was our finding that the ophthalmologist itself may see the first case of the lipohypotenosis or the multiform blepharosis. And in the second line, we included that if with the help of genetic counseling or the parent training or the finding out the mutation, we can correlate and prevent it in the families with the help of this. So these are the two things which we are going to highlight, which was the crux of our study, and we included both the points in our conclusion. Coming to the financial support, always at the end of your article, it is advisable to write out what the financial support. Like you have seen, this was our study, means we find out what is the financial impact of the survey. It doesn't means if you are doing anything on the financial impact or doing anything means what is the cost of the IOL implantation in cataract surgery. It doesn't means you have to write financial support, yes. Financial support, yes, means if this study is funded by any agency or not. So here you have seen, we have write out the nil financial support. Financial support similarly means if your study is funded by any agency or any drug trials or anything, then you have to write as. Otherwise, anything which have finance in it or finance involved doesn't means you have to write in. Acknowledgement. Again, it is advisable to write an acknowledgement for whatever or whosoever helped you. Like you have seen, we have published this an article of necrotizing panophthalmitis in the chikungunya. At that time, we didn't know, or we take the help of ligands like Jyotirmay Biswas sir, who give us and help us in doing this study and diagnosing. And again, with the help of Dr. Sasi Khare, who was the at the time the department additional director of NCDC, who helped and find out and suggested what we have to do. So these names were not involved in the authors or the author's profile at fit for that, but their contribution and acknowledgement is there. Coming to the references, that is the most important part. You have to go and find out what references you are going to add. Remember one thing, use the standard method for the referencing. There are the many methods, you know. And one of important thing is always use and index references for the articles and books. It doesn't means anything which is published in newspaper or personal communication. Most of the times you have said we have listened in that conference or journal. No. Whatever abstract you are using, references, go with a proper standard format, and also read what number and the alphabet a journal want. Few journals want author sequencing in the reference up to the 3 authors, few up to the 6, few at all. So go as per the journal guidelines. Plagiarism check is most important part. It is now important for each and every places. So before submitting, always it is advisable to go and check for the plagiarism. Now coming to the take home message, it's doesn't involve such type of study, or that if you have so much facility or the things, then you can only go and write. For writing any abstract or any scientific literature, just start step by step. Why I'm saying step by step means, first if you have plan a study, one day write introduction, then read whatever the things are there, then material methods. Once you go one by one, you can remember and find out each and every points here and there, and you can go for that. It's much easy to have write it in a step by step. This is my favorite slide for everyone who is watching. When Sachin started his test career, these today's star batsmen and cricket players were of this age. But now all are almost equal to Sachin Tendulkar or the everyone. So for yourself, don't hesitate for starting writing or educating yourself. Just start and ready to start writing. If you need any help or anything, my mobile number and email is there. You can connect me. Thank you, everyone. Thank you very much for the listening. If
Thank
any
you so
questions.
Yes, yes. Thank you so much, sir. I think that was a very lucid and well explained talk. If there are any questions from the panel, or else I have some questions of my own. Dr. Sabyasachi sir, are you there? Dr. Sabyasachi sir is traveling.
No, I'm there.
He's here.
Yes, sir. So I had a question for the panel, especially for you. So in a PG thesis, usually we ask our PGs to formulate an aim and formulate a set of objectives. So for the benefit of the PGs, could you please elaborate what an aim and what an objective is? Are they the same? And if they're not the same, how one should formulate each when they're going across a topic?
So there are two things. So aims and objectives are pretty similar. So the two main things that you need to look for is, so what is your hypothesis? And, and therefore, what is your aim? So, so one is the question that you're asking, and you're wanting to find the answer to it. That is your aim. And so, is this better than that? Or is this surgery causing enough reduction in intraocular pressure? Or, is this IOL better than that? Or things like that. So that is your aim. That is your study question. And there could be multiple. The hypothesis is a possible answer to that. What do you think is the answer? Or what do you assume is the answer? That is your assumption. So you'll say, okay, one IOL is better than the other, or maybe both are the same, or whatever that is. So the question and your probable answer is what you should start with. And once you have the hypothesis, and then, so the question is one IOL better than the other? Your hypothesis is that maybe the newer IOL is better than the older one, therefore I'm studying it, and it requires study. And therefore the null hypothesis then becomes the opposite of that. Right, and that is what you should be armed with when you go to a statistician for sample size calculation and going ahead and doing your study. You want to prove or disprove your hypothesis, and therefore you will get the right answer to your question. So so the next question is, when you come up with a null hypothesis, why is it that you have to formulate a null? What is the new need? Already there is something. Now you want to catch the nose around your ear, is because so you want to apply all of this to the whole population, but then currently you're studying that sample. It's like I am studying on the sample and I can make whatever mistake I want on the sample, but I can't make that same mistake in the larger population. So let's let the larger population be, and let's make a sort of a mirror image of that. And that's what we call the sample size, which is much smaller than the population, but it is the mirror image. And then let's do the study on that sample. Right. So therefore, the whole need to create a hypothesis and then a null hypothesis and then do a study and prove or disprove the null. So that is generally how it is. So aim and objectives are pretty similar in terms of aim could be like a one-liner and objective is a little bit more elaborate if you want. And so what is the primary and then what are the other secondary ones? And hypothesis is this answer to all of these questions. Yeah.
Right. So a follow-up question to that. So usually in the conclusion of an original article, we usually only answer the question that we have in our aim. We usually do not mention our objectives and whether these objectives were reached. We only discuss them, we prove whether or we hypothesize with them, and then we let it go like that. So is that the right way to go?
Yes. So that one-liner of aim should have a one-liner answer.
Yes.
So the one-liner of aim is the purpose of the abstract. And that one-liner answer is the conclusion of the abstract. So there go your two liners. The rest is all methods and results.
Right. Thank you so much. Thank you so much, sir. I have a question for Purvi ma'am. So, can you, for the benefit of the PGs, can you differentiate or explain to them what would be a structured abstract versus an unstructured abstract and when they would require each?
Yeah. So the first thing that I would like to tell is whenever you are planning to write any article, all of these guidelines are almost always given in the journal's instructions, either the hard copy or the website. So when you're looking at what type of an abstract should I write, whether a structured one, and if it's a structure, what kind of a structure am I wanted needed, or if it's an unstructured one, what is the word limit and how should I go about it? Everything is almost always given in the guidelines. So the first thing is always refer to those guidelines to see what kind of an abstract is needed. Now, coming to a structured abstract, it is usually written for original research articles. wherein there is basically a framework which is already given, which was shared by Dr. Deepak also, that you need to give it's kind of a summary of the entire original research article that you are writing. That is the introduction, or sometimes it is called as background. That is what is the need for doing this study. Then in very brief, the methodology, the results, and the conclusion. There is no discussion in that, right? So that is how you write the structure, and almost always it is about 250 words, because the PubMed accepts only 250 words in Medline. So if you write beyond that, it is not going to go into the Medline. So the word limit is 250, and that is what is a structured abstract. Unstructured is when this framework is not there. The content is the same. That is why you're reporting, why you're writing, what is the main content, and what is the conclusion or implication of your study. But those headings are not there. So in cases of, say, case report, case series, review articles, all those other types of an articles, you go for unstructured abstracts, and these are usually about 150 words, 200 words. It varies from journal to journal, but that is usually the acceptable, or the stated word count that is there, 150 words or so.
Right.
Yeah. And if I could just answer a little bit on the prior question also, the aims and objectives, to make it simpler for the PGs. Aim is something which very closely relates to your title, and it's a single statement, as very appropriately mentioned by Dr. Sengupta. It has to be always in a single statement. What are you aiming at? What is the goal of your study? Now, how are you going to achieve that aim? Those aspects form your objectives. That is, I want to drive on an Indian road. That is my aim. But how am I going to learn to drive? So those steps which are there, I need to know the knowledge I should have. I should be practicing here. I should be driving under supervision. I should not be having any accidents. So those steps which ultimately help me to achieve my aim, those from the objectives. And how do you classify them as primary and secondary? Primary are which those directly relate with your aim, those which form the focus, like in a comparative study between two surgeries, the primary ones would be efficacy and safety, right? So those would be a primary objectives. If you are doing anything further, any byproducts that you are expecting from your study, some subgroup analysis you are doing, maybe cost effectiveness also you are studying, which is originally not a primary intention, but you feel that since you're gathering your data, you might as well do your cost effectiveness also, or something like that, then those form your secondary objectives. So everything then put together helps you to achieve your aim.
Right. Thank
Yeah,
you so much.
thank
I have a question for Dr. Arpan Gandhi, sir.
Yes, please.
So this is more of a question which comes, does the chicken come first or does the egg come first? So usually in scientific paper writing, some people always think of framing a hypothesis and then collecting a sample size first, while some people also go on the route of collecting a set of sample size and doing something which they would call a pilot study, and then decide whether they can frame a hypothesis from that and then continue the study. So as a PG is often confused because these are the two things that is presented to them. Sometimes the professor tells them that please collect these samples and we'll see what we can do. While in the other case, the professor already knows what the result is, and the PG is asked to collect the review of literature and find out how many studies have done the same thing and go ahead. So what would be your take on that to simplify it for those listening?
So great question, and this goes through every ethics committee and a scientific committee. So it's the answer to this would probably tilt a little bit more on doing a pilot study and doing a good review of literature, and then probably having a discussion. But the other option is also a good one. I would recommend also learning as you go. I mean, if you've submitted something and there is a revision by a reviewer, or even to the extent if there's a rejection, there's always a learning opportunity, and each one of them to actually in your next paper decide, did this actually work, did this pilot study and this thing work, or should we go in for something else? So I think you learn with every experience, you learn with every rejection. There are a lot of postgraduates here. You're not going to you may not get bang on the first one, but believe me, every process, everything is different, and every study and every revision, you'll soon be reviewers someday in your life. You'll realize that you learn a lot even while understanding each revision that you recommend? And so the answer is actually a mix in both. I tilt a little bit towards the first option.
Thank you, sir. I would like to ask the same question to Dr. Lalita, Dr. Purvi ma'am, and finally to Sabyasachi sir, because he's been a part of this discussion once before as well.
Hi, I am actually Dr. Latika
Hello.
from Thrissur. So I mean, it's a great discussion going on. I would like to add some points to the already some of the points that were put forward by my co-panelists regarding the thesis by pages. So I would just like to highlight the point that it was a very nice talk by Dr. Deepak on all aspects of manuscript writing in a research paper. But I would like to highlight how a thesis is slightly different from a research paper from a PG point of view. The first thing was about the aims and objectives. Generally, we don't expect the author to give them in a research paper, but in a thesis, it is supposed to be very important, and that has been dissected very nicely by Dr. Purvi and Dr. Sengupta. So I will not dwell on that. The second point I wanted to say was that about the instructions to authors, it is very specific in a journal paper when you submit for publication. The same role is for the university guidelines for a PG thesis preparation. So it's very important that the university guidelines are followed to the dot. Otherwise, even if the manuscript is technically sound, the university reviewers may find, technical faults with it. So it's very important. And thirdly, when we all talk about the SMART objectives, and as far as the PG is concerned, I would say that the time bound, whether this work can be finished in the specific period of time and whether this is achievable would be the most important of those SMART objective criteria for a postgraduate student, whereas it may be slightly different for an original researcher. So while confirming the thesis topic, we should, as teachers, also be more focusing on these elements and PGs too. So that's what I feel about the thesis versus research paper things. That's one point I wanted to highlight.
Thank you so much, ma'am. I think that's a very important point because a dissertation thesis versus an original article is something that we need to clear out for the PGs. Dr. Puri, ma'am, any thoughts on this?
On the hypothesis and sample size, I would just like to say that it's always advisable to fix the sample size first, because to prove your hypothesis, either ways, prove or disprove or what the null or the alternate hypothesis, to make it actually statistically significant, you need to have the correct sample size. If your hypothesis evaluation you have done on an incorrect sample, then you're going to go on the wrong track. So it's always advisable that you fix the sample size first. And we as ophthalmologists are always poor on this. So again, it's always best to consult a biostatistician, decide your sample size first, and then proceed.
Exactly. I agree totally with that. The sample size in our place, we have a biostatistics department, and I actually work in conjunction with them in determining the sample size for each study.
And
Right.
it's a great idea to actually, for the postgraduates, to spend time with the statistician also, because every time they do that, there is some learning. I mean, at least the institute that I come from, the statistician gets into the depth of the subject, so you soon realize that he's also learning as you are also. So it's a great idea not to say that the statistician is going to sit different and I'm going to be doing my thing different. So it's a great suggestion by Dr. Purvi.
Dr. Sabyasachi, sir, would you like to play the devil's advocate here?
So the question I think you put forward is, should we put the question first and then proceed, or should we collect data and then proceed, right? Well, that was the original question.
Yeah, that was the original question.
Yeah. So first and foremost, a prospective study is better than a retrospective study. So when you are doing a prospective study that most theses are, then the steps are, you first decide your aims, objectives, you calculate a sample size. So you already have your hypothesis in mind, and then you proceed. Now, when you're doing a retrospective study, you could do it the other way, where you say, okay, let me collect data and let me just see. So retrospective studies have a lot of drawbacks, as all of us know. So a thesis should ideally be a prospective study and therefore should start with a study question and then a hypothesis and then the sample size and then actually go ahead and do the study. So for a PG, ideally they should follow this. That's when you will actually learn. That's when all the learning happens. So sometimes we say, oh, this question is so already done, Gisa Pita, why are you doing it again? But then the PG actually learns a lot while doing it well. So it may not be very novel, but the idea is of a thesis is not just to do something novel, but also for the PG to learn how to do it and figure out, how to manage literature and all of that. So let's stick to prospective study designs and then therefore follow the process and not, start doing retrospective study designs for thesis, where we collect data first.
Right.
I think that's a very important point. The point of thesis is not the originality is important, but more important would be to know the methodology, how to do a study. So I think it's always better. Anyway, the IRB has to clear the study, otherwise we cannot go ahead also. So the research question and the entire study design has to be there first before we can start collecting data.
Right. Thank you so much, ma'am. I think we'll move on to the second talk. So with great pleasure, I would like to welcome Dr. Shruti P. Hegre from Manipal Tata Medical College, Jamshedpur. Dr. Shruti ma'am completed her MBBS from Mysore Medical College, followed by her MS in Ophthalmology from Minto Eye Hospital, BMC RI, Bangalore. She has been a fellow of the International Council of Ophthalmology, a member of the Royal College of Surgeons, Edinburgh, as well as completed an advanced course in medical education from CMC Vellore and an FAIMER fellowship from the FAIMER Regional Institute in Mumbai. She's currently the professor and head of the Department of Ophthalmology of MTMC since April 2021, and a member of the Curriculum Committee, Institution Ethics Committee, and Medical Education Unit. Her expertise in clinics include anterior segment, phaco, with a keen interest in neuro-ophthalmology, and she has performed a lot of surgeries to her credit. And with great pleasure, I invite her to speak today on evidence-based medicine in ophthalmology. What should a resident know? Ma'am, you can share your screen. Thank you so much.
Yeah, thank you. Thanks for that very kind introduction. I'll just give me a second.
Absolutely, absolutely.
Ma'am, you're muted, please.
Yeah. Is it audible now?
Yes, ma'am. Can you go for full screen?
Yeah, sure. Yeah. Are my slides visible?
Yes, ma'am. Please go ahead.
Okay. Thank you. Thank you once again. And I want to thank AIOS and the office bearers for this opportunity. I think GuruSangam is a very innovative idea and a great platform for knowledge sharing for teachers as well as the residents. So my topic today is evidence-based medicine in ophthalmology. What should a resident know? So the topic will be mainly for residents and from the resident point of view. I don't have any conflicts of interest. So the learning objectives for my session would be that the participant should be able to describe the importance of practicing evidence-based medicine in ophthalmology, list the steps of EBM, conduct a literature search, apprise the scientific literature critically, conduct an EBM on a topic of interest in their institute. That will be the ultimate objective I hope to achieve. So my interest in critical appraisal actually began during our PG days in Minto. Our beloved late CP sir was the one who introduced us to this concept. So I still remember that. And so evidence-based medicine refers to conscientious, explicit, and judicious use of current best evidence in making appropriate clinical decisions. So the word to be highlighted here is current and best. So the evidence keeps on changing and we have to be updated with the latest evidence. EBM is basically a process of lifelong and problem-based learning. So when we say evidence-based medicine, does it mean just finding best external evidence? Well, it is not. So it is mainly there are three domains when we talk about EBM. The first one is, of course, finding external evidence. Then there is expertise and insight of the clinicians and values and preferences of the patients. So when we combine all these three, what we get is the essence of evidence-based medicine. Before I even start the process, I'll just have to tell a very brief history of EBM. The term first appeared in 1991, American College of Physicians, Journal Club editorial. Dr. David Sackett is credited with popularizing the EBM movement. He introduced the term critical appraisal. Guyat et al. Formed the International EBM Working Group, and he is the one who is credited with giving us the 5 steps of EBM. These two scientists, Suzanne and Robert Flesher, they were the ones who said that there is a wide gap between the biomedical, the basic research, basic sciences research that happens and the actual clinical practices. And they studied how to bridge this gap, and they came out with what is known as the clinical epidemiology, the essentials. And of course, the history is incomplete without mentioning Archie Cochrane, uh, in whose memory we have the Cochrane database today. So in today's session, we shall specifically focus on how the residents can conduct an EBM session, thereby enabling them to practice EBM in turn. So we want them to catch it up at a young stage so that they all become great practitioners in future. So we now start with the 5 steps of EBM. Okay, so popularly called as the 5 A's. So the first one is ask. So this is basically asking the right clinical questions. Then comes access, that is accessing the multiple resources to get relevant evidence, relevant information. Apprise. Apprise means whatever information you got, apprise the validity of that information. The 4th A comes in the application of this information to specific patient's condition. The 5th A is assess. So after applying, we assess for the overall improvement. Now what we will do is, we will go one by one, each step in detail. So the first step, asking the right question, is the most important, crucial first step in EBM. So basically we come across with various problems in our day-to-day clinical life. So converting that clinical problem into a question that is actually answerable is the most crucial step here. So like I can think of some common examples like using antibiotics before cataract surgery, optimal time of prescribing glasses after phaco, stopping aspirin before phaco, advanced glaucoma, whether to go for trab or a tube shunt. So these are some of the questions that come to us. So we have to convert this into an answerable question. A useful acronym is, as already you might be knowing, the acronym is PICO, right? So the P stands for patients or populations. I stand for intervention. C for comparison groups, or it could be a gold standard method or the standard of care with which we are comparing the new intervention. O stands for outcome. And nowadays an S is added, that stands for the study, and sometimes C for context. So based on domains, now we have to frame the question in this form. I'll give an example later on. Also, the question has to be divided on based on which domain it belongs to. Like, is a question that we are asking, is it related to therapy or prevention? Is it related to diagnosis or prognosis? Or is it related to a side effect, harm, or causality is what we are studying. Why is this important? Because depending on the type of question, we decide the type of the study. For example, if it is about therapy and prevention, we have to go for a randomized control study. As an evidence, we have to look for an RCT or a systematic literature review. If it is diagnosis that we are studying, cross-sectional study or case control study will do. Prognosis, cohort study, because they follow up the cases. Harm or causality, again an RCT, or if not, a cohort or a case control study will do. So that is why it is important to put the question under these domains. Now we are done with the first one. So we have formulated a question. We move on to the second step, that is accessing the resources. So conducting a good literature search is what forms the cornerstone of this second step. Literature search is not just important for EBM, it is important for publishing a paper, for presenting in conferences, and most important for you postgraduates, it is important for thesis. So you have to be good in conducting a literature search. So for that, we should know where to look for the source of information. So add the various search strategies. So various search strategies, of course, by that I mean, Google is always there. But before that, the prerequisite is that first you write down your research question. Try to identify the keywords and some tips about electronic searching is identifying the keywords. And if the keywords don't yield a good result, try to go for synonyms. You could use new terminologies or older terminologies for the same term. Mesh terms are important when you're using PubMed search. So the PubMed has their own vocabulary, their own dictionary. So that is a dictionary of mesh terms, combining terms using these Boolean operators. So if you want to broaden your search, you can use or if you want to make it more specific, so if you have two terms, you can use and in between. So that gives you more specific hits. And putting an asterisk at the end of the search word makes it more specific again. So now coming back to what I said, important resources. So the first one, of course, Google Baba is there. Google is there, which most of us use. But if you want to go for more scientific search, so an ideal one would be PubMed Central. So where there is a search window and we can put the terms there and it gives us the search results. There are various filters that can be used to make your search more specific. There is Scopus, again another very important search engine which gives us indexed articles. The most important when it comes to EBM is the Cochrane library that I mentioned earlier. So Cochrane it's a database of meta-analysis and review articles, usually the standard ones. So if you're going for an EBM, so please try to refer to the Cochrane. Now,
Ma'am,
sorry, I think there was some disturbance. Yeah. Am I audible now?
yes.
Yeah. Okay. So when we go for Cochrane, so this is how it looks. So I am giving an example here. I wanted to see the role of using pre-op antibiotics in endophthalmitis prevention. So I just got 3 articles. So if you can see on the left hand side, there is you can actually specify your research search by using the period here, whether you want articles only in the last 3 months, last 2 years, or you can also give a custom range between this and this date. Now, among these 3 articles, only one article was matching. So in Cochrane, I got only one article for use of perioperative antibiotics for prevention of endophthalmitis. So finally, once we have chosen the article must clearly state, as Dr. Deepak sir already told in his presentation, why we are studying the problem. So for this, you have to refer to the introduction and check if the references are adequate. If the references are of the recent ones and if they are from the standard journals. What is the problem to be solved? For this, you have to refer to the objectives. How the problem is solved, refer to the methodology. And conclusions of the paper, which is usually at the end of the discussion. So now we are done with the second step of EBM, that is finding the research article after a good literature search. Now moving on, the third step is the crucial step of critical appraisal. So this itself is a major task in ABM and what we commonly call as journal club in the postgraduate curriculum. So what is critical appraisal? Basically, it's a systematic process by which we identify the strengths and weaknesses of a research article in order to assess the usefulness and validity of the findings of that study. So in short, we dissect the article and see if the findings are valid enough to be used in our day-to-day scenario, clinical scenario. Now, critical appraisal, already I think AIOS is doing series of journal club, which are very, very helpful. These were not there during our PG days. So I will not tell too much in detail. I'll just spend few slides on this. So a good place to start. So why we have to do critical appraisal basically is we might get a lot of articles, but if the article is, if the study is not done in a proper way, that might not be, the results might not be apt for use in our clinical scenario. So a good place to start would be title, whether it is clear and informative. Research question. So whether I already told whether PICO is followed. Evidence base, references are good or not. Study design. This again I told in my previous slides. Was a study design appropriate for the research question? This is very important. Statistical tests, I was planning to say, but already this has been discussed. For statistics, please take help of your statistician in the institute. None of us are experts in this field, so they can help you with this. So whether a proper statistical test has been used or not. Otherwise, even the study might be conducted well, the data collection may be good, but if the proper test is not applied, then the findings are not very valid. The results which already Deepak sir showed, whether there is no repetition, whether the tables and the pictures are representative. So look at that. Finally, you have to conclude your critical appraisal by telling the strengths and weaknesses of the study. So what are the strengths and what are the good studies usually give in the last para, they themselves mention. I think this was also shown in the previous presentation. So what are the limitations of this study? So you can take that as well as you have to add on your own if there are any other limitations which the authors have not highlighted. Now this is the what we call as the PBM pyramid. So as you can see, as we go towards the tip of the pyramid, the validity of the study increases. So at the top is the meta-analysis and the systematic reviews followed by RCTs, that is randomized control trial. Then the quasi-experimental studies followed by cohort, case control, cross-sectional and case studies and sometimes even expert opinion. So this, although it is an ideal situation, but it is not absolute. What do I mean by that? It's not absolute because in all the contexts, this will not be applicable. Like say if you got a problem, if you got a clinical scenario which is not very common, there may not be any RCTs or even cohort studies done in that particular area. Those times we have to go for a cross-sectional and sometimes even case studies. For a very rare syndromes that we see, we have to just go for reference of case studies. So although this should be followed, this cannot be absolutely followed in all the instances. So again, now the postgraduates now are fortunate because there are checklists available. Our time this was not there. So what do I mean by checklist? There are very specific checklists present which actually tell you, each thing that I said before, there available. So for each, depending upon the type of the study design, there are various checklists. So this is the very popular STROPES checklist. This is used for cross-sectional, case control, cohort, and combined studies. There is consort statement that is used for RCTs. There is PRISMA that is used mainly for meta-analysis. Other than this, if you go to this particular website, there are checklists for all different types of articles. If you're not sure among, whether it is case control, RCT, or if your study doesn't qualify, if you're not very clear, you can follow these. So there are you can see checklists for even qualitative research. There are checklists for article on prognosis, article on guidelines. So these checklists can be taken help of when required. There are additional resources in the form of ACP journal clubs, wherein already published standard articles have been critically appraised and published. Many journals have this section where they allow the critical appraisal to be published. So there is Wiki Journal Club. So what they have done is they have summarized the evidence available in more than 120 clinical journals, and they have published it for the clinical relevance. Now, this looks like a tedious process. So postgraduates will be thinking, we already have so much to study. What is the point of doing all this critical appraisal? Is there any additional benefit? The answer is yes, there is an additional benefit. There are additional benefits in the way that future publication, this could open window for future publications. You find something interesting, you could publish it in the form of letters to editor. Or new papers could be planned from the research ideas stimulated by the reviewed articles. So you are you are appraising an article and you see that there is a gap. There is a gap in a particular between, uh, an idea is not very clearly studied and you feel that that area can be studied further. You can choose this for your next research project or even your dissertation. Now we are done with the step 3 and we move on to the 4th step. So the 4th step is applying the evidence. So as you can guess, this is the most challenging step in EBM process. So naturally, the results obtained after critical appraisal to be actually applied in clinical setting. Why it is most challenging? Obvious, because there is a lot of resistance. It's not easy to convince the senior clinicians who have been practicing a certain way of treating patients to change their ways just because you have a new evidence. In fact, study says that it takes approximately 17 years for an RCT published to be actually brought into clinical practice. So obviously this is going to be a challenge. The patient, what are the prerequisites before you actually apply this? The patient characteristics should match with that of the study participants as much as possible. Give due importance to the other two domains. If you remember my first, I think second or third slide, I told that not just the clinical evidence, but there are other two domains, that is clinical expertise available. You have done a critical appraisal, there is a fancy article available which talks about this new surgical technique, but nobody's exposed to this particular technique and they are very good in the standard surgical procedures, then this may not be valid to apply. So clinical expertise is available or not. And the most important is patient values. See whether patients are okay with the technique that you're going to apply. So ideally, patients should be made a part of your team and they should be given a chance to take a decision. So involve them in decision making. Coming to the last step, that is evaluate. So we have done the first 4 steps and then comes we have already applied, then evaluate. Like any process, take a feedback, whether it has been done properly, was it useful or not useful. So what are the things we evaluate? So evaluation has to be done on intervention, obviously, but that is not the only thing we evaluate. Intervention that we have brought into practice, we evaluate whether it was successful, fruitful or not. We evaluate the process of EBM. Was a research question properly framed? Was a literature search properly done? Was it critically appraised? And then was it properly brought into practice? The first 4 steps have to be evaluated. Patient compliance, if it's a new drug you've used or a new surgery you've done, so are the patient compliant? Cost effectiveness, very important in a country like ours. So whether the new evidence that you got and you're applied, is it cost effective? So has it brought any change in the behavior or practice of the clinician, the intervention? So all these things need to be evaluated. So as postgraduates, you might do it even after application in a single patient. You might write down what has happened, or after application in few patients, keep a track of it. And then if the evidence that you have obtained from the evaluation, if it says that it is useful, then you can actually bring a protocol in the institute. You can bring a change in the way the disease is diagnosed or treated based on your first 5 steps, your EBM process. So that completes the 5 steps of EBM. So are there any disadvantages or risks? Of course, there are. So it is time consuming when especially postgraduates have so many other jobs to do. Doing this can be a time consuming process. Sometimes there can be evidence paralysis. What do we mean by that? So this happens very commonly with us. We try to search something and there are no results available. So what do we do next? So this is called as evidence paralysis. Changing the entire protocol based on just one study may not be easy and sometimes may not be the proper thing to do also. So you're doing something very successfully and the study says that this is not so good and bring a new change. Sometimes you have to weigh with other things. So that might be a challenge. Difficulty in accessing the best evidence. This is a very important practical challenge most postgraduates will face unless you're in an institute where you get access to the databases. Most of the Scopus and Cochrane articles are locked. So getting an access could be a challenge. So in such cases, you can look for, in the PubMed, there is a filter, free text articles. So articles where free text is available, only give those hits. There are a number of articles even in that. Publication bias, we all are aware of this. So this could be two-way, that a study that is published may not be actually a good one. It just got published because of various factors, or there may be a good intervention, alternate intervention, which did not get published. So this is another factor making the EBM not so worthwhile doing. Now I have told the 5 steps and disadvantages, and we have got a brief idea about what is EBM. So I'll just give an example for the sake of postgraduates. So how to do it in a regular day-to-day case clinical scenario. So let's say that there is a male patient, 75-year-old, who has to undergo cataract surgery. It's an advanced cataract. So phaco has been planned under peribulbar block, but he's a cardiac patient and undergone a CABG in the past. So the senior surgeon who is planning to operate him wants to stop his aspirin as the surgery is planned under block, and he seems apprehensive about, but the patient seems apprehensive about the same and asks you if there is any other way. Ask the resident. So you do a quick Google search and find conflicting evidence. There are articles that say stop. There are articles that say don't stop. So what do you do? Now you're in a dilemma what to do. This is an ideal scenario. This is just an example to do EBM. So you can actually start with the first step. What was the first step? Framing the research question. So is discontinuation of aspirin really required before phacoemulsification under peribulbar block? So keywords we could use for literature search, write it down. So it could be aspirin, discontinuation, oral antiplatelets, phacoemulsification, local anesthesia, peribulbar block. So these could be some of the keywords we use for literature search. So now based on the PICO format, so the patient here is a 75-year-old male patient with advanced cataract and a history of CABG in the past. What is the intervention? Continuation of aspirin therapy. Okay, so in the patient, we can also add undergoing a phacoemulsification. So in the intervention, it is a continuation of aspirin therapy. What is the comparison? Discontinuation of aspirin therapy. So we are comparing two things here. It could be the other way also. The intervention could be discontinuation and you're comparing with continuation, both ways. Depends on what you're planning to do. So the outcome here is a safe surgery without any complications. Intra and post-operative complications are the outcome. Now, what is the type of study ideally you should be looking for? So since it is about intervention, an RCT is good. If not, a systematic literature review is what you should be looking for. Moving on to the second step. So literature search. So I just did a literature search in Google. I got many hits. but I was not sure which are the good articles. So I went for PubMed, and in PubMed I got few hits, like 49 hits, and out of which only about 10 to 15 were actually related to my study question. So then I tried to do it in Cochrane. So as you can see this, I just had four matches. But in that, the only one was matching with my research question. So this was the, one was matching with this, the first one, continuation of aspirin therapy before cataract surgery. But the problem when I opened the article was that this was under, all the cases were under topical anesthesia. So this article does not actually match with our research question. So what did I do? Again, I went back to Google and searched. So I got few good articles. Most of them were review articles. So this was going okay with my criteria, that is systematic reviews. This was a good article, but this was published in 2014. So it's almost 10 years old, more than a decade old. Then there was an article from 2019, so which was again a literature review. So I decided to go through 3 or 4 articles before coming to a conclusion. Then there was this article, which was 2020, and which was again a review article. So in Indian scenario, I got this. So if you remember the pyramid, I said that sometimes when you don't have an RCT, even the lower down the pyramid can be used. So this was a letter to editor, but they had very valid references. They had Vision 2020 documents in the reference. So I thought this could also be a good evidence. So far, most of the articles told that aspirin need not be stopped before the surgery. Again, this is purely for example, so individual opinions may vary on this. Now, when I try to further search, I hit gold and I hit a jackpot and I got an article from 2025. So this is a latest one from Taylor and Francis, which is a very valid uh, database. But the problem is this was a paid article. So now I told the problems that I discussed before. So access could be a challenge for postgraduates. I was fortunate to have an institutional access and I could get the full text of this article. So this happened to be a systematic review and meta-analysis, including 65,000 subjects. So this supersedes all the previous articles that I saw, and I decided to use this as the standard evidence for my EBM. So coming to the third step, that is critical appraisal. So as I said, this was a meta-analysis. It goes well for the question. That is, the question is based on intervention. So the title is very clear and very specific. It was done as per PRISMA, which is the checklist to be followed. Then it was registered with Prospero as given in the article. The search strategy is very clearly mentioned. I'm just going in very brief about the critical appraisal. Inclusion and exclusion criteria have been stated. Results are very clear and representative of what should be done. And strengths and weaknesses have been mentioned. They themselves say what are the weaknesses. They say there are not many RCTs in the studies. Most of them are cross-sectional studies and review articles. So they have mentioned the weakness as well. So I decided that this is fine. After critical appraisal, let us go with this evidence. Now the fourth and fifth step, of course, this was a hypothetical one. So sufficient evidence, once it is available, you can go ahead and try to, here the other, there are 3 domains. So the second domain, that is patient belief, is also going in favor, because patient is very apprehensive about stopping the drug, if you remember the scenario. So the only challenge remaining is to convince the clinician to not to stop the aspirin, if we want to go ahead with the fourth step. And after that, the evaluation can be done. That is the fifth step. So it can be done on a case-to-case basis. So I think that example, hopefully it was helpful for evaluating the steps of EBM. So with that, that was my last slide. With that, I come to the end of my presentation. So I would like to summarize that residents must be aware of the EBM because in a subject like ours, which is very fast changing, ophthalmology, every day we have a new innovation. There are a lot of gadgets, lot of new machines, lasers coming in. So it is very important that ophthalmology residents are aware of the process of EBM. So this they catch it young so that they in the future they all become evidence-based practitioners and in turn lifelong learners, which is a very important ACGME competency as well. It is helpful in scientific writing and publications, not just the process of EBM. It is not just research. Please remember, EBM is not just research and finding evidence, but integrating that evidence with clinical expertise and patient beliefs. The 5 steps of EBM, that is the 5 A's, that is ask, access, appraise, then apply and assess. These are the 5 steps of EBM. So with that, I come to the end of my presentation and I want to thank everyone for a patient hearing. Thank you.
Thank you so much,
sharing.
ma'am. Thank you
Yeah.
so much. You can stop sharing your screen. Uh, Thank you for very lucidly explaining it. And finally, when you gave the examples, it really brought the presentation to life, giving us a proper perspective of what you were trying to say.
Thank you.
I would like to just go through the panel once and first ask Dr. Latika ma'am what her take is on evidence-based medicine and her principles for practicing it in her institution.
Thank you. I think evidence-based medicine, I say it as, I mean, my way of looking at it is as evidence-based practice, because I feel that this is one of the most misunderstood aspects and a very complicated concept that many of the doctors themselves find difficult to understand. Last 2 months back, I saw an article written by a very senior physician in one of the journals about why we should not be deceived by the concept of evidence-based medicine. So I think this is an area which needs a lot of clarifications and more programs like this helping us understand what exactly it is. So I thank Dr. Shruti for that wonderful presentation. It was very lucid, often a very abstract and upcoming topic. I hope the residents will find it very useful. So in our institute, there is no one way of practicing evidence-based medicine. We don't have an SOP for that, but each of the clinicians do it their own way. I can tell you about my way of looking at it. I go by roughly what Dr. Shruti said, but regarding the question, the ask part, it is generally what I get the question from my clinical practice. And secondly, regarding the assess part and the literature search part, if it is for a scientific article, if I am going in for an original research to get a research question for an original research article, I prefer to have a PubMed search first. But if it is for my clinical practice and just to know what is happening in this, what is the current evidence going on, I generally look at meta-analysis and systematic reviews rather than going for individual articles. That's my way of doing it because I think it gives us, in less time, it gives us more concise and reliable information. And regarding the search engine, the Cochrane library and the PubMed is useful when you're writing an article. But if it is for a clinical practice and if you want the answers faster, then Google Scholar is also a very good option because PubMed is going in-depth search. And many of the articles are already, it filters it out, and because of the less reliable content. So if you're confident that you are by yourself, you can assess the reliability, then Google Scholar also may be a good option to search if you are going in for purely a clinical perspective, from a practitioner's perspective, that is. Then after that, I really do this third element of what the patient feels is very important to me. For example, that same question of whether we stop aspirin before cataract surgery. In our institute, there are a lot of, it being a medical college, we get a lot of patients on aspirin, and with all sort of, the cardiac comorbidity is not that small also. Here, the patients are more concerned about what will happen to me if aspirin is stopped. Will anything happen to me? Will I have a heart attack? That sort of patients. So I will factor in that also. And to be on the safe side, I tell the patient that if you stop aspirin, there may not be a great advantage, but then if you have to stop at aspirin, I would like to have a cardiologist opinion on that. So I send the patient to a cardiologist if that's the type of patient that we are dealing with. That is, the cardiologist should also be involved in the decision of whether that patient's aspirin should be stopped or not. This is not from, technically, it's not because ophthalmologists cannot stop it. It's because of the medical legal climate in our country, that we have to document that a cardiologist has seen, and we have, taken an opinion before we stop such a drug, because otherwise the patient may have apprehensions on that later on. So the patient's factor is extremely important when we practice evidence-based medicine. That's what I wanted to highlight. Dr. Shruti has also highlighted it in a very nice way. So my priorities would be looking at evidence critically and assessing whether this is actually relevant to my practice before I decide whether I don't just look at one article and practice it. Rather, I will look at a meta-analysis. If I'm looking at one article, I would do a critical appraisal. And if anybody is not really good at that, I think it's a bit of dicey to practice that, that kind of evidence-based medicine. Secondly, you have to go by your own experience, and most importantly, by the patient's concerns, as rightly pointed out. Thank you.
Thank you so much, ma'am. I'd ask the same question to Dr. Purvi and Dr. Arpan sir as well, but with a slight twist over here. So, evidence is coming from the statistics. Statistics is coming from the data we collect. So, there are some edge cases, for example, steroids versus anti-VEGFs in recalcitrant edema, or cases where we are seeing edema and we are deciding whether to go with cataract surgery with injection. Some cases where the evidence still is on the fence, there is conflicting evidence that is available. So how to guide our PGs in identifying the right evidence, as well as the evidence that is followed in our institution versus the evidence that is available. So I'll go to Dr. Purvi ma'am first and then Dr. Arpan sir.
So I'll thank you for asking that question, and a wonderful presentation, Dr. Shruti. That was very nice and elaborate with that example specifically. So I'll club this answer with the previous one that was just discussed, that evidence, when we talk of lot of science, we sometimes, especially the students, they tend to get carried away with the science and literature and articles, and they tend to forget or overlook the holistic perspective of a patient. So that is something which we need to, those values which we need to indulge and inculcate into the students, that whenever you're discussing about steroids or anti-VEGFs or aspirin before cataract surgery, it is not just one isolated case we are talking of. We are talking of following some guideline, or maybe, as Dr. Shruti mentioned, changing the protocol or changing our treatment management plan, surgical plan, whatever. So that perspective has to be kept in mind, considering this is not for one patient, but the guidelines we are going to follow is going to be for the subsequent series of patients that we are going to manage. The second thing is, and one more utility of EBM that I would like to say is, quite often when we are looking for, change of drugs, or something new has come up in the market, new drugs coming up in the market, new IOLs are coming up. So the company representatives, they just come with that one snapshot of their graph showing their drug is better, their IOL is better. And everybody tends to get carried away with that one image that we see. So that is also one very important place where EBM comes into picture, that we need to actually analyze the complete article, the complete science and study that was there behind that one image or graph that they are showing. what was the population, what was the scientific rigor of that study and all that before we actually start prescribing a drug or try using a new IUL. So that is also one place where EBM plays a very important role. And even in the use of literature, whether they are doing their thesis, writing the ROLs, how critically they appraise those articles and use them for their thesis work, research work, design their methodology. That is also very, very important. And journal clubs, they definitely play a very important role in critically analyzing this entire article and understanding the strengths and limitations of the articles. So that is very, very, very important.
Thank you,
Yeah.
ma'am. Dr. Arpan, sir?
Yeah, Dr. Shruti wonderfully explained. I mean, EBM is the cornerstone of modern ophthalmology. And I think the clinical decisions, if they're supported by rigorous research and best practices, is when it makes sense. And the real important thing is how you put on the research hat. The clinical practice person puts on the research hat, gets access to, we're talking about postgraduates who will now have access to high quality research. And through the country, we've seen there are differences in that. And I have seen time constraints from busy clinical schedules sometimes puts the new research in the background. So the ability to do that, and also very important, the variability in patient responses, a personalized approach, a uniform, diverse population all over the country is always going to be very different. So you have to factor in that. And don't have resistance to change, be quick in understanding how a systematic review and your clinical practice could really benefit from this. So if you can get through these challenges, I think EBM is here to stay for modern ophthalmology. So thank you.
Right. Thank you so much, sir. Dr. Sengupta, sir. So I'll go to a little bit more of a specific example. So let's suppose you have a PG with you, and right now there are around 5 or 7 new biosimilar anti-VEGFs that are available in the market, and someone comes to your clinic and tells you that he's come out with the 8th biosimilar that is available. So you want to explain to your PG whether or not the PG or or your institution should start using this anti-VEGF. How would you go about the evidence? What would you ask him to search? For someone watching this show, how should someone go about assessing a new drug, especially something like an anti-VEGF agent, which already has a lot of literature available, so it's confusing data that is available versus the new literature that comes in?
If you want me to talk about any specific agents, so anti-VEGFs is a biosimilars is a poor example. Because unfortunately, none of Indian pharma believe in clinical trials, and none of Indian physicians ever ask when they launch it, show me a clinical trial. Though the new generation is asking for it, but then so there is nothing available. But so generally, what I would tell them is, so Dr. Shruti has nicely shown us, how to synthesize that evidence, but she hasn't actually told us how to apply that evidence. What if I went ahead and told the patient, okay, don't stop your aspirin because my review article says that. And then the patient gets a hemorrhage or retrobulbar hemorrhage because that is what you're worried about, isn't it? I mean, the main reason to stop is not really cataract surgery because we know cataract surgery doesn't have implications, but it's retrobulbar hemorrhage and the patient has a hemorrhage. Then now what? So what are the chances of that still happening? So what is still the risk? So we can do things like calculate relative risk and all of that, but that's for another day. Generally, I would sort of put forward a template for application of this evidence. Is first and foremost look at whether that question has been answered, and suppose it has been answered, then look at whether your patient fits a profile of the patients who are part of those studies. Does my patient look like those? So now, if our patient is a 75-year-old gentleman who is on various antiplatelets and anticoagulants, now there are two different classes of drugs. Whereas previous studies have studied patients who are like 63-year-olds with only on aspirin and not anticoagulants. So then my patient looks very different now, much, much older, and he's on anticoagulants in addition to aspirin. So now my patient looks very different from what literature says. Now I'm back in the C because then I can't really go forward. Now, suppose, so for an anti-VEGF, now suppose there is data So does my patient look like those patients who are part of those clinical trials or part of that profile? So we need to profile our patients, isn't it? How close he is to those trial patients. We need to understand and sort of make a picture of, okay, these are who are studied, and this is how my patient looks like, and how similar is my patient to those. If your patient is very similar, then you should do what those studies are saying. If your patient is very different, then we don't know. Like, I mean, then it's going to look different. So, and suppose you do those same steps that the study said, say use the biosimilar, you should then also expect similar results. Say 80% patients had at least 2-line gain, or whatever that may be, and your patient should be improving. Now, what if the patient does not improve? If he improves, great, and the chances are that he will improve because so the validation of this synthesis process is that you're going to get similar results to what these trials are saying. That you don't get a hemorrhage, and that could be by chance because it's a very rare events in any case, right? So, so for the anti-VEGF example that you said, see, now my patient is a 63-year-old diabetic, which is very similar to the other clinical trial patient. So his vision is 624, my macular thickness is 440 microns, sugar is well controlled and all, and I give this anti-VEGF. Now the drop in macular thickness and vision should improve. And if that improvement is said by the trials that say, 70-80% should improve, and my patient definitely therefore should improve. And if then you can think about bringing in a protocol, still having an eye out for the next 30-40, saying that are all of these improving? Now, if they're not, that means there is some problem with those studies that your appraisal has not caught, or there is something wrong with your synthesis of that literature. So synthesizing evidence and then applying it, and then therefore validating your synthesis process improves this whole loop, and you keep getting better and better with every question. So that is pretty much how I would sort of put both of these in perspective: synthesize, apply, repeat. Again, synthesis, apply, watch for results, repeat. That will make you a far better clinician.
Thank you. Thank you so much, sir. I think we'll move on to the third talk. I'll just share my screen. Right. So we'll move on to the last talk of this evening. I would like to invite Dr. Chinmay from Minto Eye Hospital, Bangalore. She's a professor at Minto Eye Hospital, Bangalore and Research Institute, and a consultant squint, orbit, and oculoplasty and neurophthalmology. She completed her MBBS from Rajiv Gandhi University in Bangalore, followed by her MS in ophthalmology from Rajiv Gandhi University as well, and her FAICO from the AIOS in 2022. She has a registration of the Karnataka State Medical Association and is currently a professor Minto Eye Hospital, a consultant at Netradharma Super Speciality Eye Hospital, Bangalore, and a visiting surgeon at Nimhans Kidwai Institute of Oncology, Sanjay Gandhi Institute of Trauma, Indira Gandhi Institute of Childhood, Rangador Memorial Hospital, Fortis Hospital, and Medcare Hospital. And she will be speaking to us this evening on ocular pathology. Ma'am, you can share your screen.
Yeah, a very good evening. And at the outset, thank you for this opportunity. Ocular pathology, am I audible?
Yes, ma'am.
Yeah, so just a moment, please. I am just sharing my screen. Is the slide visible?
Not yet.
Okay.
The sharing is not on yet.
Can you unshare if you're sharing, ma'am, and then reshare it again?
Yes.
Ma'am, are you having any trouble?
Yeah, I think I'm just having a little bit trouble in
You can
sharing
just
this.
press the green share button and then press on share entire screen. And
Ma'am,
then,
can I help you in any way?
No, I think entire screen I pressed.
and then
Are you on a Mac?
No. It's actually I had an issue with
Just
my.
click on the share button on the Zoom window.
Yeah.
You have
Yeah.
the Zoom.
Yeah.
Just click on the
Yesterday.
share button on the Zoom window.
Yes.
You have a
It
pop-up.
now.
Just press the blue button. Yeah, that's it. Just open the presentation now. Perfect, man. Just make it full screen if you can. PowerPoint show mode. Perfect, doctor.
Ma'am, you can begin. Ma'am,
Doctor, one small favor. Can you just hide the toolbar on the bottom?
Ma'am, you are muted. Ma'am, you're still muted. You have to unmute yourself. Lower left corner.
Ma'am, I'm asking you to unmute. Just click on that. Unmute, please.
Okay. Is it fine?
Yeah, just go to the PowerPoint show again, please.
Yes.
Same steps.
Yes, sorry about this. So, pathologic basis of disease. So, this book, I think all of us have studied during our MBBS. And I think the fact that they kept pathology in the very beginning of the course is that because pathology forms the basis of disease. Okay, without pathology, there's no diagnosis. And that is very important. Although we left the pathology back in your second MBBS once we came into ophthalmology, I got into the studying the histopathology by my mentor, which Shruti. He's also Shruti's mentor, and she did mention about him. And he studied under Raymond Font from the AFIP. So this is the textbook which I have, and it's really an honor to have the book and to read from many of these people who put in a lot of effort to get to the basis of the disease, to go into those microscopic level. So I was very overwhelmed when I was looking at the history, like what should I tell. I wanted to put in all the names, but then you can see all the very very familiar named signs, like you have Muller's, Valsalva, Bowman, Alt, Morgagni, Fuchs, Parsons, and to Zimmerman, to the recent times. So all these people did a lot of work on the pathology for us to understand, because whenever we have the clinical sign, we have to go down to the cellular level to understand what is the pathologic process. Okay, so generally this is how it goes. So first the patient comes to the ophthalmologist, and then we do the clinical diagnosis, do the surgery, and then we send it to the pathologist, and the pathologist does some processing of the tissue, and then he reports and send us the report, and after that we confirm our diagnosis and make any change. So why is this important? Because first, to confirm the diagnosis and to alter any treatment modality. So before we go into that, I thought ophthalmologists never visit the pathology lab. So a little bit of tissue handling and how to send the specimen. So if this is the disease for us, it is like we clearly know it is in the lower lid, it is a pigmented lesion, it's involving the lid margin. But to the pathologist, when the specimen goes like this, he doesn't know if you haven't done proper marking. He doesn't know from where is the source. Pathologist is not just doing the ophthalmic pathology, but he's also interpreting from head to toe. Okay, so a lot of tissues are coming into them. So you don't when we ourselves are not so clear about ocular anatomy, how do you expect the pathologist to know from where this tissue is, how to orient this, like that? So whenever you are sending a specimen, it has to be oriented. Preferably, when this lid tumor is excised, draw either a crude diagram. See, even if you don't have to be an artist to do this, but a crude diagram as to where is the position, where is it extending, with grossly some kind of measurements, goes a great way in helping your pathologists get oriented to the specimen. Sometimes we do have to take a multiple specimens, like a map biopsy in this case of sebaceous cell carcinoma, in which each of the specimen has to be numbered so that they can tell number one, it's positive, negative, like that. So that is how the specimen has to be sent. And in what do you send? So the reason for sending a specimen in formalin is that it kind of preserves the tissue and it also fixates the tissue. Okay, so that is it. And it is a 10% formalin that we want. Commercially available formalin comes in 40% solution. So for each pot of formalin, we add 3 parts of plain water to make it up to 4 parts, and thus coming to the 10% dilution. So many a time it has so happened that in many other labs, our pathologists keep telling that the tissues are sent in saline, tissues are sent in water, and you have put formalin to a microbiological specimen, like that. So unless you sent it in a proper 10% formalin, and make sure that the specimen is fully immersed. If you just put it half, then there is again the tissue does not fix very well and it may not get preserved also. So at least make sure that the whole of the specimen is completely immersed inside the solution. And another word about labeling. So the specimen has to be labeled properly with at least 2 identifiers. And then what do you write in the request? Most of your colleges or the hospitals will have a pathology requisition form in which you have to write certain details. So name, age is very important. Let's say if you had a nevus and you just put in a number of some number as for a child, you put four instead of 4 you put 40 or something by mistake or whatever, the whole diagnosis kind of changes. And what is the nature of the specimen? From where is it sourced? It is from the eyelid. What is the clinical diagnosis? I made it a diagnosis of a nevus. Any previous biopsy? Any other relevant investigation that was done? Let us say you were dealing with a leukemia in a child, then any other hematological, like a peripheral blood smear, any other thing, x-rays, bone invasion, all that has to be mentioned. So when you give a lot of clinical detail, your pathologist will be able to do a lot of better correlation and give a good report. And as I told you earlier, the formalin is it stabilizes the tissue and prevents the decay. There are other fixatives also other than formalin, glutaraldehyde and alcohol, which we commonly do not use. Glutaraldehyde is used for the EM, the electron microscopy and all, but most commonly used is the formalin. Next is gross examination and labeling. So before the tissue is processed, the pathologist will do a gross examination and they do label the process. Now going on to the processing, there are multiple steps into this. I'll try to make it as simple as possible. I'm also not a pathologist, but I will try to do some justice to this. So this is the tissue processor and it has 12 stations and there is a container for each of the solution. So in this, the basket with the cassettes automatically they change position. Let us say this is the first container. After a certain amount of time, it move the whole container, the top and the bottom moves, and so this container tissue goes into the next one. After a set time, this goes to the next. So like that, it undergoes a whole cycle, and these are the cycles. So the first step is formalin, and one beaker is there and that formalin fixes the tissue. So why we need fixing of the tissue is that, let us assume you have a chocolate and it was in sun and it melted. Now you want to break it. It is so hard to break it, right, into a proper square. It becomes very difficult. But if it was kept in the refrigerator, then you know how easily you can break it. It is same like that. If tissues are very squishy and you cannot do a good cut, so the formalin preserves and it fixes the tissue. So that is the first beaker, and then we have the next beakers will be alcohol in increasing concentration. So there will be 6 bottles of alcohol. And why we need alcohol is that the tissue has to be dehydrated. See, the entire tissue is put in wax. So as you know, wax and water don't mix, and our tissue is made out of water. So we do not want water to be contained within the tissue. So for removing the water which is present in the tissue, alcohol is used. And there are 6 beakers in which progressively increasing concentration is used. And with that, the water content within the tissue is removed. Then next, shall we go directly to the wax? No. Why? Because again, wax and alcohol, they don't mix. Alcohol removed the water, but then it does not dissolve in wax. So now we removed water from the tissue. Now we have to remove alcohol from the tissue. For that, we are going to use the fixing agents, so or the clearing agents. Sorry. So this is the clearing agent. Most commonly used is xylene, and you also have toluene, chloroform, and benzene. So these are the other tissues that can be used to clear the alcohol from the tissue. Okay. So now our tissue is ready to be waxed. So after the clearing is done, the last step is the paraffin wax. Now, how does this work? The paraffin wax, there are 2 containers. Now the paraffin wax infiltrates into the tissue, and then it goes into the empty spaces. There is a impregnation, and then the whole tissue along with the block becomes hardened. So I am sure now that you are clear. So there are basically 4 steps in tissue handling: formalin for fixation, alcohol for dehydration of the tissue to remove the water so that you can finally wax the tissue, xylene to remove the alcohol so that the wax penetrates easily, and then paraffin wax so that now the tissue is infiltrated and impregnated and hardened with the wax. Now the embedding. So here this is a wax reservoir, and then the wax is being poured into the cassette. So as you can see here in this video, so inside this, the hot wax is poured. The tissue is being placed inside the container, and then you are putting it in a cassette, embedding this tissue inside. After that, it is closed, and again you are pouring a little more wax over the cassette so that the entire tissue is inside and it is labeled. Okay, so after this stage, it is allowed to dry, cool, and then it is demolded. After the wax block is made, now there is a sectioning of this wax. So as you can see, this is a microtome which is taking out very, very thin sections, because a thick section you won't be able to appreciate the microscopy. So a very thin uniform sectioning is being made, and this is then mounted on the slide. Okay, so these are the fine films that are being taken, and the technician puts them like this on the water, and then it is taken onto this slide. After that, we stain the slides. The commonest stain that is used is the H&E, the hematoxylin and eosin stain, but there are a variety of stains like Giemsa, PAS, Gomery stain, so Mason trichome, like that. There are a variety of stains. Commonly, after the H&E stain, whenever there is a need, we use additional stains. And now this slide, after the staining has taken up, you can see how it looked colorless, now appears colorful because of the stain that is taken. And then it is mounted, a cover slip is placed on the tissue, and we are ready for the microscopy. So this is a pentahead where in our college, where the multiple students can simultaneously view the slide, and within that we see the low power, then the high power, the oil immersion. There are different techniques for the microscopy. So again, coming back to our process, when the ophthalmologist makes a clinical diagnosis like a capillary hemangioma and does the surgery and sends the specimen to the pathologist with proper labeling, with the proper clinical requisition, the pathologist does the processing. In the processing, it is fixing with formalin, dehydration with alcohol, clearing with xylene, and then the wax, paraffin wax, slide preparation, staining, and observation and reporting. And then they send us the report, and after which we reconfirm our diagnosis, and finally we do the treatment. So as in this case, it was a capillary hemangioma, benign tumor, nothing needed to be done for him. But if it was a lymphoma, then I would further go for immunohistological studies, and then would have to refer this patient for further chemotherapy. So your pathologist report is what makes further treatment to the patient. Imagine if we didn't have the pathologist for a lymphoma case, we would be the clinician would be nowhere. Without the immunohistochemical typing, we cannot give them the appropriate chemotherapeutic agent, nor can we prognosticate the case in a retinoblastoma with high risk characters and all. So that is the importance of pathology. And now with this, a brief introduction to what happens in the pathologist lab. Now let us move on to the ocular pathology itself. Before that, what is it when it was a laborious process, right? So the whole process itself was so long. So the whole thing takes at least 3 to 4 days, because 1 day is definitely required for fixing itself. So what do you do when you want quick results? So when you want quick results, we have something called as the frozen section. So here we have a cryostat. We shouldn't indiscriminately use the frozen section, because it causes a lot of resources and time for the pathologist. So let's say we have an upper eyelid tumor and I want to do the reconstruction the same day, sebaceous cell carcinoma. So I intimate them the previous day itself to please keep the cryostat ready, and they use isopentane at minus 20 degrees to freeze the tissue. So it takes just 5 to 10 minutes for them to do this whole process of making the tissue hard, so that the microtome can cut it smoothly without distorting the tissue. So why was the entire all this process required? It was to cut a thin layer of the tissue without distorting the tumor. So that can be done by freezing the tumor itself. Just like I told the chocolate, you can just put it in the freezer for just about 2-3 minutes. It freezes and then you can break it. So that is the role of frozen sectioning. So this is how again here also we have the microtome, and it gives a thin cut, and that is mounted on the tissue. Although the histopathologic quality would be a little inferior to the standard, that is the processed tissue slowly. Now, we will be going into the clinical part of the ocular pathology. I'll be discussing it in these headings: the ocular surface, the eyelids, intraocular, and orbit. For want of time, I won't be going into very detailed pathology, but just for the postgraduate's sake, we will be mainly dealing with a very important clinical finding in each case. So this is more like an introduction for you to go into more deeper learning of pathology. So in each of this tissue, all the diseases fall into these pathologic processes. They are congenital. It could be any disease, could be congenital, it could be inflammation, dystrophy, neoplasia, and degeneration. Beyond this, there's no disease itself. So if you take nevus, it is congenital. If you say thyroiditis, it goes into inflammation. Bacterial corneal ulcer goes into inflammation. If I say there is some Fuchs dystrophy, goes into dystrophy, and neoplasia, benign and malignant, a whole bunch is there. And degeneration, any arcus senilis or pterygium, they all go into degeneration. So we have to understand the pathologic process, not just for interpreting the pathology, but also for our diagnosis and for our treatment as well. And within the inflammation, we have acute and chronic. I just wanted to put in inflammation separately, because these are the cells which are present everywhere, whether it is a neoplasia or a congenital. These cells from our blood are there everywhere. So I put this separately. We have acute and chronic, and within the acute, we have certain cells. Those are the neutrophils, eosinophils, basophils, and mast cells. In chronic, we have lymphocytes and monocytes. Now, how do these cells look like? So the neutrophils, again, they have, as you can see in the picture, you can see that the nucleus is like having multiple lobulated. And this neutrophil cell is present in acute inflammation. The eosinophils contain eosinophilic granules. The basophils have a bilobe nucleus and they contain basophilic granules. And mast cells are nothing but basophils in tissue. So basophil, when it is present within the blood, is a basophil. When it is out of the intravascular compartment and into the tissue, it is a tissue bound basophil, otherwise the mast cell, and it has certain projections also on its surface. Now, what happens in chronic inflammation? The main cell is the lymphocyte, and within the lymphocyte, it has a large nucleus. It's a fairly small cell, almost the size of your RBC, while your other cells were very, very large. And within them there are B cells and T cells, and which further differentiate into plasma cell, helper T cell, and cytotoxic T cell. For all this differentiation, we need the immunohistochemistry markers and monocytes. So these monocytes within the circulating system, once they go out into the tissue, they are called macrophages and histiocytes. So these histiocytes, when they resemble an epithelial cell, are called epithelioid histiocytes, and these can go into form Jane cells. So there are different types of Jane cells. How to see a slide? Now, once you have a slide, what does the pathologist do? First, they identify topography, like from where is this tissue? A hemangioma may be present in the conjunctiva, it may be present in the orbit, it may be present in the eyelid skin also. So based on whether it is a keratinized stratified squamous epithelium, then they will tell it is arising in the eyelid. If it is a non-keratinized squamous epithelium, then they tell it is arising from the conjunctiva. And if none of these structures are there, then it is from the orbit. So that is why it is important we write the anatomical site properly, because pathologists see the disease process more, and the topography, if we have clearly mentioned, it becomes more easy for them. The process, as I told, that is the congenital inflammation, neoplasia, degeneration, dystrophy. And then they come into a general diagnosis, and then they go into a differential diagnosis. Let us say we tell small blue round cell tumor. It could be retinoblastoma, it could be rhabdomyosarcoma, it could be Ewing's. So all these things are histopathological differential diagnosis for a small blue round cell tumor. So they then study what are the differentials for this, just like how we do the clinical diagnosis. Now, we will go into some of the tumors on the ocular surface. It is not an exhaustive list. We may miss some of the tumors, but I urge you all to see the diseases as and when they come in your postgraduate life. Read about the histopathology. I would say even Kansky is an extremely good book to refer in an outpatient, where there are histopathological diagrams as well. Now, clinically, this is a pigmented lesion at the caruncle in a young patient. I made a clinical diagnosis of nevus. Now, how does the histopathology look like? Again, as I told, this I look for the topography. Is there any stratified squamous epithelium, or is there keratinized, non-keratinized? So I don't see any keratin on the surface. So now this is conjunctiva, and it is a stratified non-keratinized squamous epithelium. And if you just grossly look at this tissue, it is mostly pink, not looking too much basophilic. That means it's more of a very healthy tissue with no malignant changes, because whenever we have malignant changes, there's a lot of bluish tinge that is being taken up by the altered nuclear cytoplasmic ratio. So grossly, when you look at a pink slide or a pink thing, it's more likely to be a benign tumor. And then we are seeing certain pigments within that. So correlating with your histopathological, the clinical diagnosis of nevus in a young patient, non-stratified squamous epithelium confirming the topography of conjunctiva, and pigmented tumor cells which are there with no altered altered nuclear cytoplasmic ratio, we can make a diagnosis of congenital conjunctival nevus. Additionally, what are the other features that tell you that it is a nevus? You can see some empty spaces. So these are the empty spaces which clinically, which we make out as some cysts. And you can also see some goblet cells, all the bluish, blue filled space. So those are your goblet cells. So that is your conjunctival nevus. And this also looks like a nevus, but then it is not pigmented. And if you see here underneath, it's very fleshy, it's very vascular. And now this patient gives a small history of a small nail injury into the eye, and after that he developed, so that is a pyogenic granuloma, which we generally call in our clinics, but then it's a misnomer. It's neither pyogenic nor a granuloma. Ideally it should be called a lobular hemangioma. So here again we are dealing with a lot of vascular channels, and so it is admixed with some inflammatory cells. So and some amount of fluid within the stroma. So that is lobular hemangioma. And then you have another vascular lesion over here. So this is a mixed AV malformation seen again in a young child. So mixed venolymphatic malformations is the clinical diagnosis. And in the histopathology, you can see a lot of vascular channels, certain areas you are seeing blood. So that is your mixed AV malformation. So inside some vessels, you can see a lot of blood that is there. So that is the thing. You can see some striated muscle fibers over here. So since this lesion was from the caruncle, and the caruncle also contains certain muscles, so that is the thing. Sometimes you can get confused as to from where is this tissue coming from. Now coming to this another lesion, finger-like projections in a middle-aged person. So clearly this is a papilloma. Papilloma you can get both in the conjunctiva, you can also get it in the skin. So highly vascular tissue, as you can see in this, after surgery, you can see how vascular it is, very, very friable and breaks. So how does it look on the histopathology? Again, a lot of vasculature is there and epithelial cells, but note that there is no nuclear cytoplasmic alteration in the ratio. Very rarely, some dysplasia can be seen in papilloma. Now here is the next in a elderly person. As you can see, it is also similar to this, but then you can see some keratin sitting on the lesion. Now keratin sitting on the lesion is a very hallmark of your ocular surface squamous cell neoplasia. And here compared to the previous case, the nuclear cytoplasmic ratio is altered. So that makes it a malignant lesion. And as you can see, the tumor cells are multi-layered and they're entering deeper into the deeper stroma. So that alteration in the structure, the altered nuclear cytoplasmic ratio, the basophilic cells make it a diagnosis of a OSSN. So now you can see the altered nuclear cytoplasmic ratio in many of these cells. You can see a mitotic figure here. Can you see the nucleus that's dividing here? So all these things point out to a dysplasia or going to a neoplasia. So that was about conjunctiva. There are multiple other lesions. I'm just showing a few of them. Now moving on to the eyelid. Eyelid is a very structure with a lot of tissues, like you have skin, you have the cilia, you have sebaceous glands, you have the accessory sweat glands, you have tarsal plate, you have conjunctiva. You can also have the accessory lacrimal glands in that. So this is the surface of your skin, and you can see the stratified squamous epithelium. You can see the rete ridges of the skin, and this is a the unit, the hair follicle unit over here. And yeah, as you can also see some muscles here. You have the muscular layer. So a lot of tumors can arise out of the eyelid. So here in a young patient, a very soft tumor appearing somewhat reddish or bluish will favor a diagnosis of a capillary hemangioma. In a other patient, a rapidly originating tumor in an immunocompromised person can also be a Kaposi sarcoma. So that is how the tissue can differ from a very simple hemangioma to a vascular malignancy like a capillary Kaposi sarcoma. So as I told, here you are seeing the keratin over here, and this is your epithelium, and you have the epidermis and the dermis. And again, as you can see, there are numerous vascular channels filled with blood, and that is your capillary hemangioma. So you can see this blood vessel, and inside them are the RBCs, and you can see these endothelial cells are very plump. We will be seeing how a cavernous hemangioma looks like, but remember, in a capillary hemangioma, they are very plump endothelial cells filled with blood. Again, coming back to a nevus on the eyelid. We already saw how a nevus looked on the conjunctiva. Histopathologically, they share similar characters, except that they do not contain the conjunctival characteristics, that is, the non keratinization and the goblet cells which were there in the conjunctiva, those won't be there. Again, here, the keratinized epithelium, the epidermis and the dermis, and the nests of nevus cells. See the brown color cells which are buried here. So gradually they progress up, and when they come between the dermis epidermis junction, it's called a junctional nevus. So usually the nevus do not become malignant. Very rarely they turn into malignant. And you can see these nests of the nevus cells. Another pigmented lesion which has a stuck-on classical appearance. So when it has a stuck-on appearance, it's called a seborrheic keratosis, an age-related change. And here again, you have multiple finger-like projections. You see a lot of keratin over here, and you see the horn cysts and the pseudo-horn cysts. So these tells that it is a seborrheic keratosis. And you may also see some keratin pearls that are seen here. So this is also seen in a squamous cell carcinoma of the skin. But if you see, the tissue architecture is very well maintained. You can see the epidermis, the dermis, you can see all the ridges. So the architecture, when it is well maintained and there is no altered nuclear cytoplasmic ratio, it goes into favor of a benign condition. This acanthoma, clinically, it's hard to miss. It's very easy to diagnose. It's a very fast-growing tumor, swelling in a young person, relatively young person, and there's a central crater filled with certain material, like a keratin material. So this is how it looks on histopathology. You have the central crater with a lot of keratin filled in that, and you have a lot of inflammation associated with that. So a lot of inflammatory cells and the crater filled with the keratin. So that is about the keratoacanthoma. And squamous papilloma, as I showed in the conjunctiva, has multiple finger-like projections with some amount of inflammation which is also there. So that is your squamous papilloma. Now, moving on to the malignant lid tumors. So here, it is very important for us to mark the tissue and send, because I want to know whether my medial margin is clear of the tumor, whether the deeper part of the tumor is free of tumor or not. So here, I already know the diagnosis. I know it is a basal cell carcinoma. What do I need from the pathology? I want to confirm my diagnosis. I want to know how aggressive the tumor is, whether my margins are free or not. Okay, so that is the reason why I have to mark and send. Now the pathologist will mark these borders, and they take this, they remove these edges separately and mount it on a separate slide and give us whether the medial margin was involved or not. And if the margin was involved, then it is an indication for me to further excise. So the commonest malignancy that we see in India is the meibomian cell carcinoma. a nodular tumor. Mostly it is seen in the upper eyelid. This particular lady has it in the lower eyelid, dirty yellow in color. And how does it look histopathologically? It is a kind of very basophilic tumor. You can see a large amount of tumor cells with foamy cytoplasm. Okay, when I tell foamy cytoplasm, look at this particular cell, it is basophilic, but then it also has some empty spaces. So that is the foamy cytoplasm. It is not entirely blue as in a basal cell carcinoma. And we have to see certain amount of differentiation. Is it a well differentiated or a poorly differentiated? Whether you can make out the cell origin properly. If it is well differentiated, it appears a lot more foamy. If it is poorly differentiated, it is more bluish in color. And to see how the growth of this tumor, we look into the mitotic figure. See, here we are seeing one mitotic figure, here again another one going here. So if we have a large amount of mitotic figures, then it means that the tumor is growing very fast. It has a higher malignant potential. So many a time in the meibomian cell carcinoma, this tumor, this is a high power, very high power view. So this is all the tumor cells at the edge, and inside you are seeing necrosis. The tumor outgrew itself, that the central part of the tumor did not receive blood supply and it went into a necrosis. So this is a comedo pattern of necrosis, which is again a hallmark of meibomian cell carcinoma. Some of the meibomian cell carcinoma can undergo differentiation to either squamoid type. You can see some eosinophilic part here, and you can see basal cells, basal cell type area here. So they can undergo differentiation. So meibomian cell carcinoma, you have to remember it's a basophilic tumor, and it is composed of foamy blue cells with a lot of mitotic figures with the comedo necrosis. So that is the meibomian cell carcinoma. Moving on to basal cell carcinoma, which is a pigmented lesion with an ulcerated margin. Histopathological characteristic feature is the cleft artifact that you see because of processing. See, tumor is very the basal cell carcinoma is like more arranged in nodules and cards. So this is the tumor, this is a normal structure. So during this processing that I told and the sectioning, the tumor nodule gets separated from the normal tissue and gives rise to this cleft artifact. So that is the first thing that you should think, okay, you are having a cleft artifact, more likely basal cell carcinoma. How are the cells at the edge of the tumor? They are arranged in a very uniform layer in a file system. So that is called palisading. So that is another giveaway that it is a basal cell carcinoma. And how are the tumor cells? They are bluish in color, altered nuclear cytoplasmic ratio. That tells that it is a basal cell carcinoma. So you have your epithelium here, stroma, and these are the tumor per se what you have here, arranged in kind of cords and nodules. That is a cleft artifact. And here you can see the palisading. All the tumor cells at the edge of each nodule are arranged very, very uniformly. And you can see it in much more detail over here. So this is called the palisading. So the characteristic feature of the basal cell carcinoma, having the individual tumor cell is a very, very highly basophilic cell with the altered nuclear, almost the nucleus filling the whole cell. So you can see these cells which are filled with. So some of the basal cell carcinoma can have variants. We saw a lot of variants like the micronodular type, the nodular type. Here it is kind of adenoid cystic type. You can see like they are appearing like an adenoid cystic carcinoma, the Swiss cheese pattern. So these are the different variants of the basal cell carcinoma. Now, the squamous cell carcinoma, the BCC form the second most common carcinoma on the eyelid. Squamous cell carcinoma is the least common in India, and generally in our practice, wherever we have seen squamous cell carcinoma, there are certain high risk characters like you can xeroderma pigmentosa or some radiation. So as in here, you can see this lady of xeroderma pigmentosa, how the tumor has grown so much into the orbit. And this is again an ulcerative lesion in the eyelid in this old lady. So here again, this particular tumor is a little eosinophilic compared to the basophilic basal cell carcinoma. And here we have the characteristic squamous eddies or the keratin pearls that are there. And again, these are epithelioid cells which are with the altered nuclear cytoplasmic ratio. Again, I will come back to the immunohistochemistry, which are required whenever the tumor is poorly differentiated. So till now, whatever we were dealing, they were very well differentiated. The Fourmi cells, you tell it's with the comedonecrosis, it becomes meibomian cell carcinoma. Palisading cleft artifact, blue cells, basal cell carcinoma. Keratin pearls, eosinophilic tumor goes in favor of squamous cell carcinoma. What if the tumor is very, very undifferentiated? Then you have the confusion. Clinically, also, you have a confusion. Pathologically, also, you have confusion. That is when we order the immunohistochemistry. So then we ask for the epithelial membrane receptors, the androgen receptors, the BER-EP4. So based on these, whenever the androgen receptors are present, favoring more of a sebaceous cell carcinoma, when the BER-EP4 is there, then it is a BCC, the epithelial membrane antigen. It is more favoring the squamous cell carcinoma. In that, the androgen receptor will not be there. So that is the beauty of your immunohistochemistry. When both the clinician is confused about the diagnosis and you have sent it to your pathologist, thinking your pathologist will give you the diagnosis. But even the pathologist, for him also, it is so confusing. The individual tumor cells nor the tumor itself are maintaining any classical features. That is when we go for the immunohistochemistry markers. Now, a rare tumor, malignant melanoma, which we saw in this patient with xeroderma pigmentosa. Again, this tumor, melanoma, composed of either spindle cells or epithelioid cells. So here you can see some of these spindle cells, some are the epithelioid cells, both are there, and a lot of pigmentation and altered nuclear cytoplasmic ratio. In these, so here we have the epithelioid cells. So yeah, so you are seeing the epithelioid cells. Many a time in the pigmentation is so high that sometimes we have to bleach the cells to know the characteristics of the individual cell. So, so much pigmentation, patchy pigmentation is present within these tumors. Certain rare tumors like a mucinous eccrine carcinoma, which we clinically it is very, you cannot tell it is a mucinous eccrine carcinoma by just clinical examination. So that is the importance of doing the histopathological diagnosis for each and every swelling that you excise and sent. So because sometimes these kind of diagnosis, rare things, will be rarely diagnosed clinically. Moving on to the intraocular tumors, I'll just speed up because I still have orbital tumors also to be discussed. Retinoblastoma itself is a huge volume. We just go into where the reporting, the tissue processing, everything is very, very elaborate. The first thing that the pathologist will comment is whether the optic nerve margin was involved or not, and then I will show it in the ocular melanoma. In the retinoblastoma, the important thing is the rosettes. So this is a very well differentiated RB. So again, I'm telling, when the tumors are well differentiated, it is easy for us to diagnose. So well differentiated RB, you have the nodules of tumor cells. When it is empty, it is the rosette, flex nerve intestinal rosette. When you have a neurofibrillary tangle, then it becomes a homerite rosettes. And when it is very well differentiated neural structures, then it becomes florets. Many a time we do not see this kind of pattern, and it is an undifferentiated retinoblastoma. Choroidal melanoma, it's a clinical diagnosis, and after multiple treatments, brachytherapy and other things, this patient finally had to be enucleated. So here I'm going to tell you something about how the pathologists do the sectioning of the eyeball. So this is a eyeball, and in a retinoblastoma, the first thing that they do is cut the edge of the optic nerve separately, so that when they cut the eyeball, the tumor cells don't contaminate the end of the optic nerve, and that is mounted on a separate slide. So that edge of the optic nerve is a separate specimen, and it is the probably the most important thing, because that determines a lot of that is a very big high risk factor, clinically as well as histopathologically. Then the eyeball is sectioned like this. So the central section that you have is called the PO section. That is the pupil optic nerve. So that is a pupil optic nerve section, and the top two caps of the eye are called calots. Okay. Further to this, then they do vertical sectioning of each of these tumor. So that is called bread loafing. So when the eyeball is given, whether it is for a retinoblastoma or for any other intraocular tumor, the PO section with the optic nerve and the pupil is the central section. Two peripheral caps are called the calots. And here we can see the choroidal melanoma here, and this is your retina, your lens. There's another type of sectioning where the eyeball is cut horizontally like this. That one, which contains, when you look at the eyeball from the back, is called the Miyake apple view. When you see the ciliary bodies, so that is the Miyake apple view, and it's really a very, very beautiful view of the eyeball from the back. So this is the large slide on which this tumor is mounted, and you can see the structures. So here we have the sclera, we have the optic nerve here, and this is the tumor per se. And here you have your retina that you can see here, the layers of the retina. Again, here also you can see the layer of the retina. And how the microscopy, there's a high power view where you are seeing lot of tumor cells, a lot of pigments everywhere scattered, and on high power you see these epithelioid tumor cells with the altered NC ratio, and that is your epithelioid type of the choroidal melanoma. I'm skipping all the reporting guidelines. Please look into the international guidelines which are there for reporting retinoblastoma and the choroidal melanoma. Moving on to the orbital tumors, some of the vascular tumors, earlier we discussed capillary hemangioma. I'm showing you the cavernous hemangioma, which I discussed earlier. So here, in contrast to the capillary hemangioma, which had plump endothelial cells, here we have very flat epithelial cells. We have large cavernous spaces, very large spaces. That is why it's called a cavernous hemangioma, filled with a lot of blood. So that becomes your cavernous hemangioma. Like I told earlier, the capillary hemangioma in this child uh, treated with intralesional steroids, you can see that there are some depigmentation arising here. Here, in a capillary hemangioma, the tumor cells are very plump and smaller vascular channels. This is the channel, small vascular channel. Here is one, here is one, here is one. In a cavernous hemangioma, they are very large channels with flat endothelial cells. The commonest orbital disease is metastasis. So here we can see the signet ring adenocarcinoma of the stomach. You can see the typical signet ring cell that is there that clinches the diagnosis. Many a time, patient first comes to the ophthalmologist. I have seen a patient, many patients of breast carcinoma presenting first to us like a six-nerve palsy and all. And when we did imaging for them, we found some mass in that. And later when you check, they actually had a breast carcinoma. So all sorts of tumors can come into the eye, because mostly into the muscles, into the choroid, because they're very vascular. The next common orbital condition is the lymphoma of the orbit. And in a lymphoma, you see monomoniacal cells. All cells look very, very similar. Very, very small blue round cell, very compact cell, highly pigmented. So almost it looks like as if the entire the whole cell is filled with the nucleus, very very tiny cells. So this is lymphoma. If you have multimorphic cells, then it becomes a lymphoid proliferation. So if it is monomoniacal cells, it is lymphoma. Different types of cells in various stage of differentiation, it is more of a lymphocytic proliferation. So here again, you can see the cell with the very, very large nucleus. So another child who actually presented as trauma eventually ended up as AML, because here again, as I told you earlier, the relevant hematological picture is very important. Peripheral smear showed clinched the diagnosis, and here again, it is very similar to the lymphoma, very very small round blue cells within that. Other characteristic features to differentiate further leukemias are there. Tumors arising from the muscle, rhabdomyosarcoma is the commonest orbital tumor in childhood. And as you can see, this also looks like as I told earlier, small blue round cell tumor, histopathological diagnosis, RMS, undifferentiated retinoblastoma, Ewing sarcoma, lymphoma, leukemia, all this look very similar. But the differentiation, it's like sometime when you have some striated muscles, muscle-like structure, it goes more into the RMS. The neural tumors, as you can see, this is a nerve, and you can see these wavy structures, spindle cells, and all. They favor nerve, eosinophilic in nature. So this particular patient with a large tumor with a lot of necrosis in the center, clinically we diagnosed as a schwannoma, because you can see the nerve here. You can see the superior orbital nerve over here. So we sent the diagnosis as a schwannoma, and you can see on gross examination the yellowish tumor that is there, and you can see the classical Antony A and Antony B tumor. So Antony A is the hypercellular uh, area which contains spindle cells, uh, and the Antony B, which contain a lot of loose matrix with the cells distributed. So this is the spindle cells. Whenever you have spindle cells, it could be muscle or it could be nerve also. It could also be the malignant melanoma spindle type variant. So that is how we differentiate the spindle cell. And here they have these wavy structures and the pinkish epithelium, pinkish cells favoring more of a here you can see them more clearly, the wavy nerve fibers which are there. In This is a case of meningioma. Okay, I'll skip the slide. And here we have the plexiform neurofibroma with the sphenoid dysplasia. And as you can see, it's a very highly vascular tumor, and they contain the bag of worms which you can feel during surgery. And you have this very lot of nerve fiber bundles. You can see all those wavy nerve fibers within the tumor. Some of them do have some inflammation associated with that. Moving on to the lacrimal gland tumors, pleomorphic adenoma, as the name itself tells, is pleomorphic. So you have many different cells. You have the lacrimal gland acini over here. You have bone and cartilage over here. A lot of stroma which is there. But maintains the nuclear cytoplasmic ratio. That becomes pleomorphic adenoma, versus another elderly patient with a lot of bone invasion. As you can see, bone is invaded, entering into the brain. Clinically, adenoid cystic carcinoma. Pathologically, also proving to be an adenoid cystic carcinoma, having this classical Swiss cheese pattern. And as you can see, like I told you earlier, the nerve fibers over here. So this tumor is infiltrating into the nerve. So that is your perineural infiltration, hallmark of this adenoid cystic carcinoma. And this is the tumor invading into the bone. You can see this pink tissue with the acellular pink tissue, that's your bone. And this tumor is invading into the bone. So I think I'll skip the IHC markers, because that itself is a very, very big chapter for want of time. Uh, a quick note on that, they help in better understanding. And whenever we don't have the morphological features, the architecture is lost, the cell itself has lost its characteristic structure, that is when IHC markers are helpful. They help us move towards the truth. And like I already told, some of the markers that are there, epithelial membrane antigen, the EP4 androgen receptors, P53, there are a host of immunohistochemical markers which are there for the help of the clinicians and the pathologists to formulate diagnosis and to tell the prognosis. So I think I'll stop at this. Thank you very much for the patient hearing. I hope it will be helpful for your exams. And I think it's more like I want to stress the fact that histopathology forms a very, very important part of diagnosis and treatment. And postgraduates, please read the histopathology, because when you read thyroid pathophysiology, you know the different types of cells, and based on what cell was involved, then you can give them proper therapy. You can give them corticosteroids. If you know it's a T cell mediated thing, there are a lot of new drugs which are coming in. So you can use all those drugs when you come down to the molecular level. Today's talk was more about histopathology, but I urge you all to read more in depth into the pathologic processes. Thank you very much.
Thank you so much, ma'am. I think this should have been called an ocular pathology masterclass. Because you've really,
I'm sorry, I skipped a lot of lesions, like a very important ones also, like OSSN and all. But then I think it just makes them more interested. It's more like an eye opener. And one thing is like wherever you are practicing, try to make a point when you send to the pathology. Your patho
your
PG is
screen.
also no, there is no need of screen.
Can you unshare your screen?
Oh, sorry. I think I haven't
Yes,
tried.
now you have. Now you have, ma'am. Yes.
Okay. Yeah. So usually you also have your pathology co-PGs who are there in your hostel. So it's a good idea wherever in centers where the clinicopath meets are not happening, you can just casually talk with your PGs. It will help both of you, to both the pathologist as well as you, and make a habit to visit the pathology lab.
Right. Thank you. Thank you so much.
Thank you.
I'll just ask for some concluding remarks from each of the panelists, and then we
Yes.
can wrap up for the evening. I'll start with Dr. Shruti ma'am, and then Dr. Purvi ma'am, and then Dr. Arpan sir, and finally Dr. Latika ma'am.
Well, yeah, as you rightly said, it should be called a master class. And knowing Chinmay ma'am's passion, she's my senior from Minto, a teacher as well. And we were all inspired by CP sir.
Yeah.
So, yeah, ma'am, it was very informative as usual. And I think, yeah, it is all said and done. It is difficult for ophthalmologists to develop this, but I think it's very much needed. It's a need of the hour that PGs have at least a basic understanding about the common pathologies, the common histopathological findings as told by you.
Yes, Shruti.
Dr. Purvi ma'am.
Yeah. Thank you, Dr. Chinmay. That was being a glaucoma specialist. I'm quite distant from all these things. Medical educator, still far away. So it was a wonderful and a very visually enriching presentation. Yeah, so it has been an overall wonderful webinar. So for the PGs from the first talk, I would just like to convey one small take-home message that start writing whatever format you can, maybe just a simple case report to begin with, and read more and more papers so that itself will help you to write better. From Dr. Shruti's presentation, just one take home message that critical appraisal of whatever you read or whatever is shared with you or put forward before you is very, very important, because nowadays there is so much of information available everywhere. So critical appraisal forms a, a core or integral part of taking into science or utilizing it for your clinical practice. And from Dr. Chinmay's, I can just say that for PGs, yes, proper labeling and a little bit of history giving with the sample is very, very important for the microbiologists, pathologists, histopathologists. Because our own pathologists and microbiologists, histopathologists, they keep complaining of the same thing, that either they are not taken properly, they are not labeled properly, some background history is not given. So it becomes very, very difficult for them to, correlate and gather the picture. So that is something which really needs to be kept in mind. Thank you.
Thank you, ma'am. Dr. Arpan, sir.
Yeah, Dr. Chinmay, beautifully explained. This is the domain that I specialize in.
Yes.
Well, it's very heartening to see such a beautiful presentation, and you covered the pre-analytical, analytical, and post-analytically beautifully. I was actually thinking of what point you would have missed. So whatever I'm going to say is probably something you did emphasize, or maybe needs more emphasis. One, the orientation of the histotechnician is extremely important. A histotechnician should be very well versed with ocular samples. It's he who or she who does the embedding and the process after that. So that process, apart from the ocular pathologist being oriented, and apart from the postgraduates oblique fellows visiting the lab and orienting, which you beautifully covered, it's also the histotechnicians. Very important part in this is to use good quality reagents, to keep changing them. A tissue processor requires frequent changes. The volume of formalin should be at least 10 times. The container, we get samples from 40-45 centers. We've tried to standardize the containers coming in as well as the packing. It's very important to understand, you could have put in 10 times the volume of formalin, but if you have a leaked one, you're going to get an autolyzed specimen. So that's about pre-analytical. Analytical, I already covered about the history thing. And about post-analytical, there's a huge scope of collaborative work, research work in ocular pathology. I know for sure that there is a lot of chance for, we talked about publications and all, there's a lot of chance to have ocular pathology as part of your publications, because obviously it goes with cases. And there's a huge scope to also use it for research and collaborative work. So that is something that that postgraduates should look at. And also an aspect that's coming up and should be used is digital pathology and AI pathology, which is in for ocular histopathology. We're working on it, and people are also across the globe working on it, because ocular histopathologists are, there are very few in the world and in India. So the more you can use AI and digital, the more it reaches out to various geographical areas. So beautifully covered, and I love the talk a lot.
Thank you so much, sir, for reiterating these facts, which I missed, and it's really a pleasure to me to hear good comments from you. Thank you so much, sir.
Thank you so much. Dr. Latika, ma'am.
Thank you, Dr. Chinmay. Being a retina person, whatever you showed and whatever you said was really an eye opener to me. And I'm sure that for most of the residents also, these things usually fall in our blind spots. We are not looking beyond the eye and what happens, in the pathology, how they actually work. It was really, really wonderful listening to you. So I'll definitely ask my residents who are not watching this to come back to this again and again. Thank you so much. And regarding just one point, I thought I should make regarding the research part, that is the use of AI, because most of the residents now are quite smart, and they are very prone, and they all like, and they do use a lot of AI, basically ChatGPT. But I think the use of AI is good in certain sections of manuscript writing, like probably referencing, and also probably in writing down. I mean, the actual process of language editing and writing down. Other than that, using AI can be quite problematic. if the person is not well versed with what they are trying to do. And there are certain chatbots which are useful for certain things. And I think for referencing the research rabbit, consensus, insightful, etc., are very useful, especially when they have a problem with getting original articles. Consensus especially gives article summaries. It might be good. So AI can be used in smart ways. And coming to original article, if AI is being used, it's important to acknowledge also, because editors are now looking at AI plagiarism, and there is this GPT-0, which is a software exclusively for that. So that is also important. So that's all I needed to add to it. I'm very thankful to AIOS and Dr. Santosh Honavar and everybody behind this for including me in this program. So enjoyed it. Thank you.
Thank you so much, ma'am. I think that brings us to the end of today's webinar. I think you finished well within time. I would once again like to thank all the speakers, Dr. Deepak sir, Dr. Shruti ma'am, and Dr. Chinmay ma'am, for excellent presentation. This is an excellent addition for the archives for PGs to look back. I would also like to thank Dr. Arpan sir, Dr. Latika ma'am, Dr. Purvi ma'am, and Dr. Sabyasachi ma'am, as well as Dr. Geeta ma'am, who couldn't join us this evening, for all their valuable insights. It's really amazing to have a galaxy of such esteemed faculties from different subspecialties bringing in their experiences for PGs this evening. Once again, extreme gratitude to Dr. Santosh Manawar sir, Dr. Manoj Mathur sir, and Dr. Samar Basak sir for conceptualizing, executing, and being the umbrella of this session all throughout all these weeks that it has been going. Thank you once again to our support admin for all the support that we're getting so that we can have these smooth sessions and we can not rack our brains behind hosting these sessions. That brings us to the end of this. Thank you very much. We can stop the live.
Yeah, thank you.
Thank
Thank
you.
you.